صباح الخير واهلا وسهلا بكم في الوركشوب ورشه العمل الخاصه بالناشونال كلينيكال جايدلاينز. شرفتونا طبعا ونورتونا، و with your permission انا هتكلم من انجلش دلوقتي علشان الاكسبرتس اللي معانا والتيم من الامرو. Good morning everyone and welcome. Thank you so much for joining us to the technical workshop on the national program for guideline development and adaptation in Egypt. My name is Riham Al-Asadi and I am from the country office of the WHO in Egypt. أهلا وسهلا بكم again. It's a great pleasure to be here. It's a great honor. And I want to start by thanking everybody who's here. Many people have come from different governorates and have traveled. Some people traveled today, actually, 4 hours to come here. So thank you so much. I'd also like to thank our expert team. There's going to be plenty of time for introductions, Dr. Paul, Dr. Nathan, and Dr. Edith. And of course, the support of our regional office team, led by Dr. Arash Rashidian and Dr. Mehernaz Khirandish, and their incredible support. And the team here with us is Malika, but also others in Emro. Without any further ado, I'll pass on to Dr. Mohammed Fawzi Souda, the head of the General Organization for Teaching Hospitals and Institutes, to start us on the program. تفضل دكتور محمد.
بسم الله الرحمن الرحيم. صباح الخير. I would like to thank His Excellency Dr. Khaled Abdel Ghaffar to start this mega project that put the medical service in Egypt in the first step of the right route. And thanks Dr. Naima and WHO organization and his colleague for her great support that make us can come out our dream. And thanks of all to have to come today and suffering from the cold weather and the bad traffics. And I hope we can do something to our country after these 4 days, and we can start a unified medical service, qualified medical service, and accredited medical service in our country to change our health and change our people's lifestyles and life quality. Thank you again, and I hope that you give us your times in the next 6 to 12 months to have these guidelines in the to become true and to be implemented in our hospital. Thanks.
Dr. Naima, can I invite you please to start us?
صباح الخير وكل عام وانتم بخير. احنا بعدنا في أول شهر من يناير وأنا سعيدة جدا أكون بينكم الوجوه الخيرة. أنا بتكلم باللغة الإنجليزية علشان خبرائنا يكونون اللي معنا يعرفون أين نحن. I just said good morning, happy new year, and I think Paul and Edith and Dr. Arash understood me fully, but still I decided to speak in English. Okay, so very much I would like to echo what Dr. Fawzi said with His Excellency Dr. Khaled Abdel Ghaffar's leadership on really bringing the concern of how can Egypt practically walk the talk and do the transformation. You have 100 million Saha. How many of you are involved in 100 million Saha? Raise your hand. People who are involved in 100 million Saha, raise your hand. ارفعوا أيديكم إذا أنتم عاملين في مجال 100 مليون صحة. Okay, less than 10%, Doctor. We make a note, and then I will ask you the question again. Now, today we are here on a very, very critical, we see it as a milestone in Egypt. And I would like to acknowledge Dr. Fawzi, who has been appointed as the chair, and also the committee members, and especially the technical committee members. I would like to see the raise of a hand of people who are working directly with Dr. Fawzi on the technical arm of the higher committee on clinical development of clinical guidelines. Very good. You are more numbers than the ones with 100 million صحة. Yes, and still some are coming on the way. I want to give this because I want to give a picture for where we are and where we want to be by the end of the week. I'm very pleased and honored also to introduce Dr. Paul Garner, Emeritus Professor, Liverpool School of Tropical Medicine, who is very well known to be working in this area. And at the same time, you will have two health economists with you from WHO. One of them is Dr. Nathan Paul Ford, chair of the, Dr. Nathan, where are you? Dr. Nathan is sitting on my left. Ahlan wa sahlan. Dr. Nathan, actually, how many of you know him? Raise your hand. Can you stand so they can see you, Nathan? Did you see Nathan last time when he came here? Dr. Murad, raise your hand. I see you didn't raise your hand. Okay. Dr. Fauzi, raise your hand. Why I'm saying this, Dr. Nathan was here for 1 day last time, and it was again for 2 days with Dr. Arash Rashidian. Dr. Nathan is actually, Paul Ford is the chair of the Guidelines Review Committee at the World Health Organization headquarters. I'm giving the names because I want to say that WHO is very much committed to this flagship area of work that Egypt is going to lead. Egypt is the largest Arab country, is the second largest country we serve in the region. I'm looking at Dr. Paul and Dr. Edith. But I want to give you a message with Arash Rashidian, who is my colleague from Director of Science and Evidence Division in WHO. And actually, I call it always IER, which is Information, Evidence, and Research. To me, this is where we want to show that there is a good basis and elements for here in Egypt. We are believing that you can bring the change by really having a unified voice, and I'm pleased that we have members of human rights here also to talk about the rights to the patients, safe, right care, safe patient care through the clinical guidelines and development and adaptation. But when I mentioned about who is here around this room, because I was trying to reduce my intervention. Today we are having several key people around the table, experts from the ground. I was recognizing some of you earlier, but also from colleagues, my colleague Dr. Nathan, Dr. Arash, Dr. Mehrnas. I don't know how many of you know Dr. Mehrnas. She has been with you before. She has gone to the Guideline Center, but I'm trying to bring that all of us are here to bring a change. I mentioned about the health economist, Dr. Edith and Dr. Ahmed Khalifa. Where are you, Ahmed? For a reason. Whatever you are doing here is not just to reduce the cost of care. It's actually to give efficient, cost-effective, safe care to every individual through your practice using the guidelines. 2 years and a half ago, we had the COVID-19 when I came here. It was its peak. And I was surprised that every entity have their own guidelines, and everyone called it national guideline. National guideline for COVID treatment, Ministry of Health. National guideline for COVID treatment, higher education. Ministry of Defense, are you here? Anyone from Ministry? Ministry of Defense is here, but today they are in their civil suits, so I'm very pleased you are here. Ministry of Interior, ahlan wa sahlan. But today in this room, there is a demonstration that we are all working together, all the sectors, and I'm asking to raise hands for a reason, to show that we are having very different sectors, different practices, different specialities coming under one room to decide on a systematic preparation for clinical practice and clinical care based on evidence. There are several pieces that has been here already. I don't know whether we have anyone from Universal Health Insurance. في أحد من التأمين الصحي؟ UPA, EDA, Egypt Drug Authority, General Authority for Health, I believe they are coming. Okay, we have General Authority for Health already here. Very good. So we do have the different disciplines, and it shows that you are here to bring a change. The guidelines that we are talking about is a core function of WHO. My history is that when I first joined WHO in Geneva, the first committee member I was put on was actually review of the guidelines of WHO. It was fascinating. We just saw within our own organization, we are using different methodology and different practices to bring the guidelines. Today we have designated person and committees, and everyone is working, and Paul can explain to you, to do a guidelines review committee, and this is one of the functions that you will be doing, Dr. Fauzi. I'm putting some of the elements. But the same thing that we are trying to do is how can we improve the health and well-being and accelerate achievements of the goals, vision of 2030 in Egypt for a healthier population. People who did not raise their hands that they are part of 100 million Sahha, I think you will review when you know you were part of it under curative care. Because 100 million Sahha was not only HIV, it was not only hepatitis, صح? It was not only hepatitis C. And I am repeating it because I forgot to tell our experts. 100 million Sahha is several sub-initiatives under presidential. So we have political commitment, we have the will, we have the people. And what you did the early detection of hepatitis C, but also you did the early detection of the 4 non-communicable diseases, right? How many of you are in the heart specialty? Okay, 2, 3. So you are part of the 100 million Sahha. صح? Okay. We also did hypertension, respiratory diseases, cancer. How many of this room are in this specialty? Okay. And last year, there was an initiative for renal detection and renal care. Okay. So if I see now more hands are rising, in the under 100 million Sahha, the protocol of care after early detection was you, people who are clinicians. And the same thing, you were bringing the evidence on what best to give care. I always give the experience I had in this country in 2010, coming in a country that had the highest hepatitis rate in the world, 2nd or 3rd in the world. Coming after 10 years, you are seeing one of the lowest, almost lowest in the world. Why? Because the 100 million Sahha addressed it universal health coverage from 4 angles: early detection, early treatment, which is you, because you needed to do the protocol of care, prevention, blood safety, infection control, safe injection, safe surgery. Dr. Nabil Tuwaider was saying, I'm general surgeon. What I want to bring the message is that all of you are in the different part of the 100 million initiatives. This is an initiative to bring a very concrete guidelines that standardized to be followed. Dr. Fauzi talked about accreditation. I don't know whether General Authority for Health Accreditation are here. But accreditation is also looking, and health insurance are looking into the cost that costs to the country to have healthy people, but at the same time not be at debt. ما نكون مديونين. So we are looking at the diagnostics, we are looking at the drugs, and we are looking at all these angles. I am putting these pieces for you to know that they are actually part of the initiatives and moving, and this is a very critical component of the initiatives that brings sustainability to a health system, consistency in our practice based on evidence, and more importantly, to demonstrate the transformation of the different authorities for the health of the people as a right to be in a safe treatment, safe care, and at the same time with all slowly unified voice on what we want to do. One of the last message I want to give, and Dr. Majdi is sitting here, Jasser and WHO Egypt team, Amira Hijazi and Ahmed Surur, and Anoha, we are working with the government on the clinical governance. There are 4 entities, Dr. Majdi, or now becoming 5, because I know University Teaching Hospital will be joining. Clinical governance is from facility and from the hospitals. And I'm giving this history because you have 4 days of interventions, so we all have the basis of where are we with the transformation of the health system. It's not only just seeing a patient, it's the patient, the family, the community of the healthcare practitioners, the specialists, but also the larger community of having the safe environment. So to me, the clinical governance and patient safety are the core for this, leading to the hospital accreditation one way or another, leading to actually look at the cost of the services, cost of care that is skyrocketing in many countries. And I think we want to show that with having the right clinical protocols guidelines that guiding us to develop clinical protocols based on the evidence that actually is going to bring a better future. The health economists are here to look at with us also from the angle of the investment case of the right use of the technology, the right use of the medicine. And when I say technology now, we are also jumping into another area, the telemedicine, the telehealth, healthcare online and healthcare. Very soon is going to be metaverse, Doctor. Paul, are you ready for metaverse? Yes. So I wanted to bring a message. Now, how many of you are part of 100 million صحة? Thank you very much. دكتور رفع يدك انت hard. يعني ما يصير رفعوا يديكم. Just I wanted to go how we are because sometimes public health angle is very important. It's our goal, but also we do not forget that there is a care that we need to give and there is a protocol of care on how to give the care. I would like to thank you all and took time, but I wanted also to brief us in, as a team under one umbrella. I want to give the floor, with your permission, to Dr. Arash Rashidian. Will you be the one to be speaking? And then I will be listening.
Yes.
Sabah al-Khair. Assalamu alaikum. Very nice to meet you all. I'm Arash Rashidian, Director of Science Information Dissemination in the Regional Office of the WHO. It's my pleasure to be with you. Obviously, as you know, the Regional Office of the WHO is based in Cairo, so we are always in Cairo. But today, here we are in the real Cairo, so working with the country, Egypt, and the focus is here. So I want to, after the excellent introduction by Dr. Fawzi and Dr. Naima, so I want to just raise 2 points so that we move to the agenda and the introductions that my colleague Dr. Mehnaz Khairandish will give after this. The 2 points are, first is about the national guideline program that Egypt has started under the patronage of His Excellency the Minister of Health, and the work that all of you and also under the coordination of Dr. Fawzi's team you are doing. So when we talk of national guideline program, it's not about individual guidelines. I mean, Egypt has guidelines for many years. There has been many, I mean, there are many cases that we've been exchanging with colleagues about the processes. Obviously, the quality varies, the format varies, and the use varies as well, and sometimes there are competing guidelines. At the same time, all of them are guidelines. There are methods used in them. So again, the quality of methods might vary from one to the other, but still they are following an approach to come out. When we talk of a national guideline program, it's not just about a program to have guidelines. It's a program that brings all programs of guidelines together. There will be a sort of plan for those. There will be a quality assurance process. There will be a minimum standards. There will be an approach that would say which guideline is allowed or is considered to become a national guideline for a country. So what are the minimum criteria? So let's say you come from different backgrounds. If your society is developing a guideline for a problem that you feel is a priority and it needs a guideline, then how that guideline can qualify to be called a national guideline. Answering those questions while we are also expanding the capacity. So what we do in this workshop is basically trying to do both. So there will be a lot of discussion on technical aspects of it, much more detailed than the workshop we had in November. Some of you have attended very few of you. I can see faces that I recognize from the last workshop in November. So we go more into details of the methodologies. So how they are applied in practice. The reason is that the audience we have today you are meant to lead those processes, to be on the committees, to actually guide the processes. The second thing is that, so when colleagues are working together, it's also, even if you are not going to do the methodology, the people who work on the guideline, they all should have the same understanding. So if a question comes, well, why can't we accept this piece of information that looks like evidence, so what's the reason? And if you want to challenge it, how we can challenge it? And what are the things we can do while still we keep it as an evidence-informed clinical guideline or public health guideline? So bringing all those aspects together. That's the aim. we will do it also similar to the last time. I mean, will be sort of open discussion. We've been asked to consider, I'm coming from the region myself, my background is from the same region, but we've been reminded several times that in Egypt we like to ask questions, and we know that, and that will be more than welcome. There will be a lot of discussion through the process. The second issue I want to highlight is that for us in WHO, obviously we do that under leadership of Dr. Naima for Egypt. But for us in WHO, and my responsibility is 22 countries of EMRO, the case of Egypt is not just supporting Egypt, it's actually showcasing how WHO can support a national program. And that's why we are working so closely, because of the sort of the work that, the way that Egypt has come forward as part of a sort of a national request, very committed minister, very committed authorities. I mean, some of the teams that you raised, you asked about, they were actually present in the previous workshop, the senior colleagues. So we had also from other ministries on all previous workshop that we had. So the work of WHO coming together with Egypt to support technically your program, to be with you while you are developing the program the way you want it and the way you implement it. And then for us in WHO, we also will use the experience of Egypt to help other countries. And also to show other countries, because every other country has guidelines. Some other countries in the region, they actually have national plans, but the implementation is not ideal. So we would love to see that Egypt does it the best way, so that we actually encourage more countries to do also the best way that you will do, inshallah. And it's our Lord to be with you. So with that, again, thanking all my colleagues, thanking country office, thanking Ministry of Health and all colleagues to see. And in a way, I mean, we are at home and we are with you, and hopefully you will enjoy the workshop and the experience and the exchange that we had.
Sure, it's my pleasure. Hi, good morning, everyone. So, yeah, I was hoping that I can just open it as soon as I can. Okay, we are happy. We should say we are happy, maybe. Okay, so I will just go fast. As you know, we had in the introduction and opening remarks some of the areas that I wanted to cover just to keep ourselves in time. I am Mehnaz Khairandish, Regional Advisor for Evidence and Data to Policy in the Eastern Mediterranean Region, WHO Regional Office. So I will just quickly go through the objectives that we will have. So there are two main objectives of this workshop. The first one, we want to enhance our technical capacity in conducting guideline development and adaptation. So we will have, as Dr. Naim and Dr. Arash just kindly mentioned, we will have different technical sessions, and we will have different group exercise and working groups in the terms of having some hands-on activities to do together some of these practice to know how we can conduct technically a kind of guideline development adaptation process. And also another objective of this and aim of this workshop is to have some trainers at the end of this workshop who can hold the similar workshop for other colleagues relevant and who will be involved in guideline plan in country, in Egypt. So in that case, we will share, as previous time, we will share the slides with you. You will have access to the slides. Also, the recording of this workshop, the recording of previous one is almost ready. So the two recordings will be shared with you. And after this, we think that having these documents and having the trainings after this 4-day workshop, we will be able to have the same training, the similar training to other colleagues in the country. So just in a nutshell, we will have 5 technical sessions, and in each session we will just focus on one of the aspects of guideline program. We will have some theories and presentations, and then we will have several question and answer sections, as well as we will have different working groups. We will have 6 working groups during these 4 days. That some of the documents just shared with you, the printed, and there will be more maybe print documents that will be shared with you for these 4 days. And at the end, we will have our concluding remarks and also the way forward. Also, hopefully we will have Excellency Minister of Health on the last day, which he will just deliver kind opinion remark, concluding remarks. I'm not going to again repeat for the introduction of the distinguished speakers and trainers as Dr. Naima. She kindly just did this introduction. And we were supposed to do a kind of roundtable introduction of the participants, but considering the constrained time that we have, just to keep ourselves in time, so we have different respectful representatives from key stakeholders relevant to guideline program in Egypt. So Dr. Naima mentioned some of the names, so you can see the different stakeholders that we have. We have members of High Council, we have colleagues from GOTI, Minister of Health, Egyptian Health Council, Healthcare Sector, Ministry of Interior, Medical Association, Minister of Defense, universities, and Unified Procurement Authority, Universal Health Insurance Authority, and National Clinical Guidance Center Executive Team. But my request from you is whenever that you want to talk as a first time in the working groups or in the working presentations, group exercise, please introduce yourself, your name and your affiliation. So in that case, everyone will know you better, please. So thank you for your attention. I hope everyone a very fruitful and great workshop at the end. And now I just want to invite my colleague, Dr. Nathan, for the first presentation on Introduction to Guidelines. Dr. Nathan, floor is yours.
Okay, so thank you everyone. Thank you for the kind introductions, and it's good to be back here in Cairo for this follow-on from the meeting I was at just a couple of months ago. I noted that a couple of you were here when I was here a few months ago, and this is largely a presentation that I did give last time, so it will be a little bit repetitive to a few of you, but I hope it will provide a good basis for what we have to do in the coming days. So as has already been presented, I work in the headquarters office of the World Health Organization in Geneva, and one of my functions is as the chair of WHO's Guideline Review Committee, and I'm going to give a very brief presentation on guidelines from a WHO perspective. So this is just one example of why guidelines are important. So this was a news item from the United Kingdom a few years ago, showing that £5 million a year was wasted on needless wisdom tooth surgery. And this was because surgeons were making individual decisions about whether people needed surgery or not, and the National Health Service spent a lot of money on an intervention which, when the evidence was appraised and assessed, it became clear that it was unnecessary. A lot of people were having surgery who did not need surgery, and it was through the evidence, the careful evidence assessment process, that it became apparent that this one single intervention was alone costing a lot of money to the UK health system, and after the evidence review it was disbanded. And this is one of the sources of information that led to evidence-based guideline development within the United Kingdom, and it is hoped that through future guideline development, health services across the world will be able to save this, if not much more money, through adhering to standardized guideline development processes. So why do we develop guidelines? We develop guidelines to provide policymakers, practitioners and patients with clear guidance, to provide decisions on appropriate courses of action, whether an intervention, practice, policy, medical device, diagnostic, or other is standardized across the health system. Best practice on available evidence that has been critically appraised, and we'll be hearing a lot more of that as the days go on, and transparent considerations of other relevant information. Transparency is a key word in guideline development. It's that anyone reading the guideline can understand how the people who, the recommendations that are being put forward were developed. What is the underpinning evidence and rationale for making the recommendation that you're making? And the only way that people can fully understand that is by being transparent about who was in the room, what evidence did they look at, and what process did they use in order to arrive at the decision they arrived at. And so transparency is another word we're going to be hearing a lot about in the coming days. Why does WHO have a guideline review committee? So as I mentioned, I'm the chair of WHO's guideline committee, and Arash is the vice chair. So together we oversee the quality assurance process for the development of guidelines that are published by WHO. And this process, the Guideline Review Committee, was established in 2008 following a public appraisal of WHO's guidelines that found that back then WHO guidelines were formulated by a process that where evidence was not systematically achieved, appraised, synthesized and interpreted using systematic and transparent methods. So WHO guidelines, when they were being developed back then, did not retrieve the evidence systematically. They didn't use transparent methods to arrive at the decisions, and the process relied heavily on a small group of experts. And this criticism was taken very seriously by the Director General of the World Health Organization, who rapidly put in place the Guideline Review Committee. And no guideline published by WHO today cannot be published without first being approved by the Guideline Review Committee. And the following slides will give a very brief summary of the type of methods that are used to ensure that guidelines adhere to high and internationally recognized standards. So the handbook for guideline development was published in 2008, and this is the handbook we still use today with a few minor modifications, but it forms the basis for the quality assurance process at WHO. Guideline development processes must be explicit and transparent, with a clear scope, objectives and target audience, multidisciplinary, including all relevant expertise and perspectives, with detailed and transparent funding sources noted as part of the guideline process, and adhere to clear reporting standards. The relevant contributors of a guideline must disclose and manage their conflicts of interest, and that is put in the public domain. And recommendations that are put in the guideline should be actionable, clearly articulated and precise, informed by the best available and most recent evidence, and supported by a rationale with a summary assessment of the evidence included in the guideline itself. So this is a snapshot of the broad range of guidelines that are produced by WHO. Recommendations on digital interventions for health system strengthening, recommendations on non-clinical interventions to reduce unnecessary cesarean sections, risk reduction of cognitive decline, HIV guidelines, housing and health guidelines, and guidelines for the management of region-specific infectious diseases, in this case human African trypanosomiasis. And this is just to give you an idea of the breadth of the different levels of guidelines that are being produced by WHO. So we broadly have 3 different types of guidelines that are being produced. On the left-hand side, we have the standard guidelines. These are full guidelines covering all the interventions across a disease area. They typically take between 6 months and 2 years to develop, but they're very comprehensive. Then in the middle, we have rapid advice guidelines. These are compressed and abbreviated processes that can take 1 to 3 months, and it's to address an urgent public health problem. And then we have emergency interim guidelines, typically the guidelines that were produced in the last few years to respond to the SARS-CoV-2 pandemic. They're very narrow scope. They have a relatively limited short shelf life, and they can be based on indirect evidence, existing guidance, or expert opinion. And the reason these abbreviated processes are used are because member states need guidance from WHO immediately, and these guidelines are produced in a matter of days or weeks. And some of the COVID guidelines that WHO is producing still follow this emergency interim process because evidence is being generated on a very rapid basis, and member states are looking towards WHO for immediate guidance to let them know whether this new medicine to treat SARS-CoV-2, for example, is a medicine that they should be considering to use in their national programs. The guideline development process, we're going to see more of this in the coming days as well, but this is a quick flow diagram summarizing what WHO does from start to finish when it's developing a guideline. We first of all scope the guideline, so what does the guideline need to address? What are the key questions that need to be asked in the guideline process? Put together a panel, the guideline development group experts who are going to look at the evidence, appraise the evidence, and formulate the recommendations. Ask some key questions and select the outcomes that we're looking at that are associated with the key questions. That's the planning process. And once that plan is put together, it's reviewed by the Guideline Review Committee, considerations are given, and then finally it's approved, and people can keep going with the guideline development process. They retrieve the evidence, they conduct systematic reviews, they appraise the certainty of the body of evidence using the grade process that we'll be hearing a lot more about in the coming days. Recommendations are formulated, and these recommendations are formulated on the basis of explicit considerations of benefits and harms, resource use, feasibility, health equity, non-discrimination, human rights, and socio-cultural acceptability. And that draft guideline is once again approved by the Guideline Review, reviewed and approved by the Guideline Review Committee, and then it's disseminated and implemented with appropriate training and tools to support uptake and implementation. And finally, the impact of the guideline is evaluated, which gives information about what needs to be considered when the guideline is updated within a given period of time, usually 2 to 3 years. So who contributes to WHO guideline development? We have the steering group. These are people who are experts in a given field, employed by WHO, sitting in headquarters and regional and country offices. They form the steering group that help guide the process along. Then you have the guideline development group. These are external experts, unpaid individuals who give their time to support WHO's recommendation formulation process. So they're the ones who are responsible for formulating recommendations. It's not people sitting in WHO headquarters, it's a panel of external experts that help WHO to establish the recommendations that are included in guidelines. In order to be a guideline development group, expert member, the management of conflicts of interest, there's a very clear process for that. They do not represent institutions that they work for, and a guideline panel aims to achieve balance both in terms of gender, geographical representation and expertise, and it can often include the end user perspective, the end user being the patients themselves. And then we have a guideline methodologist who helps to ensure that the minimum standards are followed, the minimum standards of a trustworthy guideline are followed, including the evidence appraisal process and the application of grade. And our colleague here today, Professor Paul Garner, has acted several times as a methodologist for WHO guideline development processes, so we're in good hands this week. And then there are a number of other people who are part of the guideline development process, meeting observers, the external systematic review team, and other people who could be important stakeholders of groups affected by guideline recommendations developed by WHO. So the declaration of interests is really, really important to ensure that there are no important conflicts of interests among the people associated with the development of guidelines at WHO. WHO has a policy that was established almost 10 years ago. It's regularly reviewed with a view to see whether it needs updating or not. What we look at, typical conflicts that we look for are employment, including consulting, research support, investment interests, financial conflicts of interest, intellectual property, intellectual interests, and public statements and positions. So financial conflicts of interest are important, but they don't stop there. Intellectual conflicts of interest can be equally problematic in the formulation of recommendations. And we need declarations of interest from the guideline development group members, the methodologists, and the external review team, so everyone who's bringing the evidence to the table to formulate recommendations. We get public comment period. We put the biographies of the guideline development group members in the public domain, so anyone in the world who may have an issue with the experts contributing to guideline development can review and note if they have concerns. And it's only after all of that is done that the guideline development group panel is finalized. Grade, I'm not going to talk much about this in this opening presentation because, again, we're going to be hearing more in the coming days. But grade, as a headline, is a common, sensible, and transparent approach to establishing the quality of the evidence that's put on the table and the strength of a recommendation that should follow from the evidence that's being looked at. The quality of evidence is often, and more frequently these days, referred to as certainty of evidence. So you'll hear these words interchanged, quality and certainty of evidence. And the certainty of the evidence is based on 5 things. Limitations in the detailed design and execution of a particular study, let's say a randomized trial of a drug. Inconsistency. You look at all the studies that have been done. Are they all pointing in the same direction, or do some studies say that something works and other studies say it doesn't work? How consistent is the evidence? Indirectness, are the studies addressing the question that you are asking, or are you using evidence for a different question and trying to apply it to your question? Imprecision, are the studies large? Do they give reliable estimates, or are they tiny studies that don't give statistically significant outcomes, and so there's an uncertainty with respect to the imprecision of the results? And publication bias, is what you have on the table all of the available evidence, or is it only some of the evidence because other studies were done but they were not published and you couldn't find them when you did your systematic review? And factors that can increase the certainty of the evidence is a large magnitude of effects. So did the intervention lead very clearly to a change in outcome, reducing the number of people who died as a result of a health problem? Has all the biases been accounted for when you reviewed the evidence? And dose response is another important consideration for upgrading certainty of evidence. And we'll, as I say, we'll hear a lot about this in the coming days. So the strength of a recommendation reflects the extent to which we can be confident that desirable effects of a management strategy outweigh undesirable effects. A strong recommendation, which you'll see in WHO guidelines, we formulate recommendations as either being strong or being conditional, and they can be recommendations for an intervention or against an intervention. A strong recommendation is a recommendation where the desired consequences of adherence most likely outweigh potential undesired ones. It means most reasonable people in a given context would want to implement a strong recommendation, and most patients would want to receive the recommendation. Whereas a conditional recommendation, the guideline development group, having reviewed all of the evidence, is less confident that everybody would accept the intervention. They would say that many people would want the intervention, but some people would not. There is variability. The implications of a strong recommendation, this is repeating myself. Most people in a situation would want the recommendation course of action, and some would not. A conditional recommendation, the majority of people would want it, but many would not, and it requires shared decision making and the involvement of a wide group of stakeholders to achieve acceptance of the recommendation. Factors affecting, we've already talked about this with respect to the certainty of evidence, but it doesn't stop there. It's also values and preferences. What do clinicians think about the intervention? What do patients think about the intervention? What are the values and preferences associated with a given intervention? Cost and resource allocation. Is it more costly? Is it less costly? And less cost-effective interventions are less likely to receive a strong recommendation. And other factors include equity, acceptability, and feasibility. All of these are put together in what we call an evidence to decision-making process, and we're going to hear more about that in the coming days as well. So the rules of procedure for group decision-making, this is what WHO follows, that WHO recommendations should be based on consensus. And first of all, you have to decide what your definition of consensus is. Is it 100 people, 100% of people in the guideline development panel have to agree for it to be consensus? Could it be a simple majority that 51% of people agree? Or do you apply a different threshold? Often in WHO, we use a majority consensus, 70%. Minor disagreements can be noted in a guideline. If there isn't full consensus achieved, sometimes we use part of the guideline narrative to explain why there was not full agreement, and voting is often used to achieve consensus. So when you're looking at a WHO guideline, usually follows the same process. You first of all have the recommendation, then you have justification remarks, why was the recommendation made, implementation considerations, what should people think about when they're trying to implement the recommendation, and research priorities, what has been learnt from this whole process in terms of the evidence that's missing. What should future researchers consider in order to help improve the evidence environment next time round? And so in summary, WHO guidelines aim to achieve the highest quality standards for evidence-based guidelines. They focus on UN member states and end users' needs. They're based on high-quality systematic reviews of all the relevant evidence. We'll hear more about that in the coming days. We use the grade process to assess the certainty of the evidence that comes out of the systematic review process. We incorporate multiple processes to minimize bias, and all judgments and decision-making are transparent and explicit and include a clear management of conflict of interest. So that's my opening presentation. I am going to be with you for the next few days, so if you have any questions, I'd be welcome to try to address them. Thank you very much.
Thank you. My name is Paul Garner. I am honoured to be with you, and thank you, WHO, for asking me to assist. You need to know about me. I'm a medical doctor. I started on guideline work many years ago in Papua New Guinea with a little handbook for primary healthcare workers, and helped do the umbilical cord care guidance for primary healthcare workers. I then became an academic and helped set up Cochrane. So I was one of the people setting up Cochrane, where we started pushing out the process of doing systematic reviews as a way of accumulating evidence. One of our early reviews was of impregnated mosquito nets, where the individual randomized controlled trials had some evidence of an effect, but until you did a meta-analysis, there was the meta-analysis of those trials showed a convincing impact on mortality, about 20% child mortality. So this showed the power of accumulating evidence in systematic reviews. And I worked in Cochrane infectious diseases for till a few months ago. And but at the time, systematic reviews and their connection to policy, everybody knew it was a good idea to use systematic reviews in policy, but then nobody knew quite how to do it, because you need to take all these other factors into account. So I've worked closely with WHO. Have you got the... Okay, thanks. In formulating these methods, but also WHO can enable the development of the methods and guidelines for countries, but actually decisions need to be made at a national level. And I've worked with Thailand, quite a lot of work in India in TB guidelines, with adapting and actually generating their own guidelines, and in COVID as well, and in Kenya and Ghana. And I think it's very important that this is done nationally and then out through the system. So that's my background. I'm a methodologist by trade, which I'm having a bit. How do I move it on? Which one is it? Oh, it is. Oh, right, thank you. Just to point out that I come from Liverpool, which is a beautiful city, and if you've not visited, you are very welcome there. And also, just to point out, that Liverpool is here. London is here and Liverpool's up here. So I'm not at the London School of Hygiene. I used to be, but I'm from Liverpool, which is in the north. So if we say guidelines are statements that help make decisions in particular circumstances, when I was a medical student, I looked at episiotomies and the effect of routine episiotomies, because all women were receiving episiotomies when I did obstetrics, if they were prima gravidae. And I went back to look, where did this come from, that it protected the perineum, prevented incontinence in later life, prevented third-degree tears? And it came from a paper in, I think, 1944 by Flew in the British Medical Journal that said, I've just done this procedure, and here it is, and it helps avoid a lacerated perineum and morbidity and so on. And I've just done it on 10 of my private patients, and I think it's a jolly good idea. And this then spread out. The logic behind this, the rationale, spread to the time when I was doing obstetrics. Everybody was having, all the women were having an episiotomy. And this was an example at the time of evidence of medicine made by consensus by specialist experts. And specialist experts can be right, but they aren't always. And sometimes these things need to be questioned, and you need to draw on research, and subsequent research has been done in this area to show that the benefits that were purported to be there are not. Episiotomies sort of guarantee a damaged perineum. So going into tropical medicine at the Liverpool School of Tropical Medicine, I'm not sure, we had this overlying empire effect of people, Brits know about telling people what to do. This is really perhaps just to show you these slides. I hope you can see them from the back. They're just extraordinary. These are British colonial service telling people in the Punjab about how their best health. Be vaccinated against smallpox for every 7 years, and when there is smallpox in the locality, good message. Drink plenty of pure water half an hour before or 1 hour after meals, and rather than with meals, and play out of doors every day and always breathe through your nose. So this was really to Britain helping people get better. And always be regular in going to the latrine. That was obviously sort of things that the Brits are obsessed by. So, you know, this colonial side has been also part of it. And the old system for developing guidance was GOBSAT. GOBSAT is a phrase you're familiar with. Good old boys sat around a table. And when we started with WHO, that was largely the approach that was used. And so using relevant research was very important, and using systematic reviews was very important, because what people tend to do is select studies that support their point of view. So the critical appraisal of the research that relates to the review question is really central to it. And for some reason, researchers work really hard in minimizing bias in the primary studies, but at the time, the scientific principles were out the window. So the systematic review, which we will be dealing with and talking about later, uses scientific methods of protocol development and teams of people to assemble the evidence. Nathan has already mentioned this paper that pointed out the problem in WHO with this, that many of the guidelines didn't follow this a process using systematic reviews. And I think it's going to be quite difficult for you at the back to see this, but the clever way that's emerged with NICE and other guidelines organizations is to separate the synthesis of the evidence from the decision-making process, so that you've got one bit, which is where people like me come in doing the systematic reviews, and then there's the decision-making process, because you need experts, everybody in this room, their clinical experience, their interpretation of the results, their understanding of what happens in practice, what is feasible in their setting. That is central to the process. So it's important to get across the idea that this is a group process that goes alongside. You systematically summarize the evidence along the back, on the bottom, and then within the groups that you used before, you have a structure and a way of everybody looking at the evidence collectively and understanding what it means. And it really does work. So really, just to add then, guidelines are systematically developed statements to assist practitioners and patients make decisions about appropriate health care for specific circumstances. And what I'm going to be also encouraging people to think about is the big questions where there is clinical or public health equipoise in a particular area, because those are the areas you want the panel to focus on in the reviews. It's not every single detail of the care pathway that comes with time. It's one of the big questions that you need to look at. So certainly I'm going to be covering what is a good systematic review, helping with the process from moving from a systematic review to a recommendation, and looking at some of the components such as managing conflicts of interest that are important in the formulation of the guidance using the systematic reviews. So that's my introduction. As I say, I'm very pleased to be with you. Thank you very much.
Thank you so much, Paul. Can I open the floor for any questions, either for Paul or Nathan? Any questions from the floor? Yeah, sir.
So, good morning. My name is Dr. Samah Shaheen. I'm professor of cardiology in Ain Shams University in Cairo, in Egypt. And I'm the past president of the Egyptian College of Cardiology. So, I'm coming from a field of cardiology where we are blessed with tens of guidelines. And it happened that I'm very much involved, still involved in the committee of the guidelines in the European Society of Cardiology. So every year from the European Society of Cardiology, we have 4 guidelines in the field of cardiology, different guidelines, different topics. And every guideline is almost about 50 pages. So I'm asking this because I want to get a step backward from the beautiful presentations that I heard. Is why do we need a national guideline? I don't understand me wrong. I'm a full fan support of a guideline for my practice. We don't depend on personal experience anymore. So yes, we need a guideline. But why do we need a national guideline? While, in fact, I have the European Society of Cardiology guidelines, I have the American College of Cardiology guidelines, I have even the NICE sometimes if I want to dig into the British experience. So do I really need a national guideline? Because I'm asking this question because I have my concerns or my doubts. Because the evidence that I'm depending on is a universal evidence. The mega trials are universal. So again, I will look at the same trials that have been studied and looked after by the European Society of Cardiology. So I'm repeating again what they have did, the major efforts that they have done. I know that I have difference in Egypt, that maybe the Egyptian patient is different from the British or the Spanish patient. But do I have the Egyptian evidence to change the guidelines? I was, a couple of years ago, horrified by the Egyptian guidelines in hypertension. Why? And I was a member in this, and I went away because they were changing the level of treating Egyptian hypertensive patients from the international level, which is 130/80, into 150/100. Why? Because we don't have the money to treat patients with mild hypertension. On what evidence do you have? Are you recommending this for your father if you have a father that you don't give him treatment? And what about strokes if you don't give a treatment? So I mean that you are not allowed to change the evidence on just the cost of your country or your limited resources unless you have evidence. So we don't have Egyptian evidence. So this returns me back to my question is, why do we have national guidelines? This is my first one. The second, more important even question is, I'm concerned more about implementation of guidelines. We have hundreds of guidelines, but it was never in the hands of the practicing physician in Aswan or in Asyut or in Sohag. Although I was, as a president of the Egyptian Society of Cardiology, very much involved in educational efforts to implement the guidelines, I mean to be sure that the guidelines are reaching every small young doctor in faraway regions. But I think that more important than putting a guideline is how to implement the guidelines. That's what we are missing. Thank you very much for my question. And I'm really eager to hear from the experts in this field.
Thank you very much for this elegant meeting. I'm Ahmed Abdelaziz from I'm consultant in intervention cardiology, National Heart Institute. Dr. Sameh raised a very nice question, and I will talk about my experience in National Heart Institute and in Gothi. I'm the head of pulmonary hypertension unit in the National Heart Institute. We know that we have guidelines, international guidelines for pulmonary hypertension since 2015, working on it. But on the practical field, when we started working, we noted that we can't implement all the lines of the guidelines because of many things. One of them is the cost. Second thing is the availability. Third thing, that some things in the guidelines, implicated in the guidelines, that doesn't match our practice. Like, we have something in the systemic sclerosis, it's called the detect algorithm, to decide whether to do echocardiography for patients or no. This was based on what? In America, the echocardiography costs $5,000. So they have to put an algorithm to see who will benefit from the echocardiography to be cost benefit, okay? In Egypt, echocardiography costs nearly 30 pounds or $30, okay? If we implicated the algorithm of the detect to do the echocardiography, we will cost more and we will take more time to do the echocardiography that costs nothing, actually. So when we saw that we are practicing in pulmonary hypertension in isolated islands, and we are a small committee, we did what's called Egyptian task force for the pulmonary hypertension to see what we were doing over the past 10 years in pulmonary hypertension on the ground. And we collected our data, and we are doing our national registry of pulmonary hypertension, collecting data from all centers that are working in the pulmonary hypertension on the current practice, okay? Based on somewhat on the national guidelines, of course, but we modified many items in the guidelines to match our Egyptian work. And we found that we are all without agreement, before agreement, that we all agreed on some practice that led to the same results in the registry of the patients. After giving the treatment in our practice, not in the guideline practice, fully guideline practice, we found that we matched it and we had the same results in our registry like the other registries in national heart, in the national registries in France and America and in even Saudi Arabia. So I think we have to put some modified guidelines based on many things. One of them is the economic. One of them is the actual practice, not the theoretical practice. And I think we will be surprised when we implicate something like this. Thank you.
Adaptation is what you're doing at the moment. And so I'm not here pushing for the global guidelines to be thrown away. You're adapting them and doing what you see as fit. What I would say to you is that finding areas of priority which you are seeking to do in primary care and in secondary care is important. Using variations in practice can help indicate areas of equipoise, or where people are doing. Quite often people assume everybody's behaving in a particular way outside of their own clinic, and they're not. People are doing very different things. So it's not my job to come in and say what you should and shouldn't do, but certainly looking at variations in practice, looking at whether it's feasible for everyone in the population and not just the specialist clinics. You also raised an important point about national data. And of course, you don't need trials from within the country to support a particular way of working. That doesn't make any sense. You will look at the evidence in the systematic review and make sure that it applies to the patients in your practice. And that's part of an adaptation process that might take you back to the formation of the guidance. So we had, and I can only answer you indirectly, say that, for example, there was a lot of debate within the circles that I was working with COVID, that WHO was coming out with COVID guidelines. And we were working with South Africa and very, quite closely with India, with a group making guidelines. Exactly the same questions that WHO had talked about the previous week. But there was a real need for the clinicians within the country to work on whether this intervention made sense in their own context. And of course they came out with different decisions quite often to what WHO had come out with. WHO wasn't very pleased, but you know, that's part of the application. But part of the transparent process of working out where the area of equipoise is, where there's an important priority for you as clinicians and for the health of the public in your country, in your area of primary care or specialist care. Working out what that is, looking at existing guidance. Some areas are well stocked with guidance, with panels that you just adapted in, and that's okay. And maybe in your national decision making, those areas get parked and they're not the priority areas for you to move forward with. So I think the process for guideline development is sort of at national level is in your hands, but I suppose that the purpose behind these thoughts are how you can have the technical skills in or use the processes that are there in adapting them, using them, prioritizing them, and internalizing them in some way. And so in India, we worked in extrapulmonary tuberculosis, and there's USA guidelines on this, but there was a very and we focused on 3 areas. Gene Expert had just come in, so they were trying to work out whether to use Gene Expert. And actually, there wasn't a consensus across all organ systems with TB at the time. So they did come out with some decisions that were different to WHO. So I accept everything you're saying, and I think it isn't what's going on here isn't sort of replace this or put some other process in place, but to work with you on it in trickling in some of the methods, finding the areas that perhaps aren't so well covered or a bit neglected, or where there is a lot of uncertainty. We're working with a group in Echinococcus at the moment in the treatment of that, which involves poor people living in rural areas and surgical procedures that may or may not be recommended. But there's clearly within the guideline group lots and lots of people doing different things in different ways. And so a guideline also is about bringing together sort of a consensus around the different. So if you've got different the same condition with very different forms of care being used, it's unlikely that everybody's going to be right. So I think I would encourage you to be open to looking at ways of further standardizing equitable care so that the things you recommend do reach the people throughout your country.
Yeah, I mean, sort of, we'll have a session today, just later, we will discuss the issue of adaptation, adoption, and the issues. And I think both cases that were presented were real issues that clinicians deal with at the time of decision making, but also at the time of what to do next as well, in terms of the planning processes. And the way I heard it, I will explain that justification, is actually both cases support a national plan. None of them are against a national plan. And when we one of the things we do is that in the discussion we will have, we try to identify different elements of how a national plan should work. Deciding whether a European guideline is good for Egypt or not, that's a decision. How that decision is going to be made, that becomes a national plan. So that's adopting a guideline. In a way, on the other hand, look at the basic principle we say in guideline development. So Nathan was referring to that, and so Paul. So we say multidisciplinary, all relevant teams being there. Part of that is ownership. Part of that is interpretation of evidence. Part of that is the context-related issues. And the context-related issues are not only cost, but there are also the service delivery approaches, the referral system, the availability of resources. There are many examples like that. So if we say, well, this principle is a good principle, then I would argue if some of the best doctors around the world sitting together, issuing a guideline, that's valuable, but that's not covering all disciplines that are required for a given country. So that becomes a sort of argument. So in a way, you bring the argument in, you what are the principles we need to follow, and then you use the best available to you that is coming, and then for that you have a process. And when you say, okay, now we accept this, then this becomes that's what called. And that would actually also push the issue of the implementation much better, because then everybody is responsible for it, rather than the people who actually have the direct task of cardiac sociology, but is also the managers become responsible for it, the insurance program becomes responsible for it. So all of them come together. One example of such this, from my old days in the UK when I was working on NICE guidelines, that goes many years back, a very clear clinical case. So there was a NICE guideline on management of head injury in hospitals. And there were different scenarios and cost effectiveness assessments programs that were coming forward that they were recommending. So if someone has a head injury, the first thing you do, and then this is, over 20 years ago, 20 plus years ago. So the issue was that, CT scan is expensive. Start with a head X-ray. Usually the trauma can be seen visibly, and then you can decide whether you do or not. And then the guideline committee, and this was coming actually based on some guidelines that had been issued in the US, elsewhere, etc. at the time. Then the guideline committee reviewed that, and then they decided to recommend against it. Why was that? The main cause of head injury at the time in the UK was actually drunkenness. People who get drunk, they have accident, one way or the other, and that was the main cause. So then the clinicians in the committee had said, well, we have all the evidence coming, but if I see a drunk person with head injury, and if I see a skull X-ray, I cannot interpret that easily with the skull X-ray. So I was doubted whether I need to do this or not, because if I see signs of if I see the injury, I'm not sure it's because of the injury that they are clumsy, or is it because of the drunkenness? And if I don't see it, I don't know whether it's something that I cannot see. So I really need the CT scan to make the decision. So that became the recommendation that the first line of diagnosis is CT scan. At the time in the UK, the radiologists did not have night shifts. So they would work until late afternoon, and then they see everything in the morning. So when this guideline became the national guideline, it actually required changing the practice that for this to be done, we actually need to have shifts for radiology. So then that becomes that's the concept of national guideline thinking. So in a way, bring all the elements together.
one national for all at the end and causing all this.
Dr. Sameh and Dr. Abdulaziz, you raised very critical questions, and I'm sure it is on the mind of majority in this room. And that is something that we should keep it at our forefront. My experience has been different. I served in a country that it was 3 countries. And each country of this country, sub-country, believed that they know what is it, and they know what is it, and WHO just should put a stamp. I will just give example on the clinical guidelines. The specialists believe that they can rely on UK, US, and they do not need anything for the national. Not looking that they are part of the health systems to bring equity and equality, and also they have committed to be responsible and accountable. So if you have these values aligned with the adaptation, what does it mean if you cannot get the same diagnostics measures or equipments or whatever that is there? What does it mean between what we call the generic medicine, which is equally effective, efficient, compared to the branding, which is very costly? What does it mean in terms of equity and equitable access that was mentioned by our experts? So today, these are some of the questions will go to you in your mind between today and the last day, and I'm sure it's in the mind of everyone. I will give you another example within this clinical guidelines. There was a debate at the highest level, and it will be a very funny story, because we're talking about the CT scans and MRIs, and everybody wants MRI, everybody wants CT scans, everybody wants the highest technology, right? But then the equity that was mentioned between the variation of center capital versus the governorate, the remotest, is against the values of equity, accountability, delivering, and all of us making the oath to give the best delivery of care. The funny story is that in the meeting, this is high level, this is including Minister of Finance sitting there, including the parliamentarian, I was challenged as the WHO, saying, what's wrong with you? If we can bring a Sony TV, and that one can bring a LG, I don't know, they talked about the TV and technology, why you are not allowing us? And immediately I did for them a calculated cost on their TV selection. I'm not talking about MRI, but they were relating to it, on what does it mean cost to the country in terms of bringing the product for diagnostics, if you want, for maintenance of it, for training of the specialists on it, be it radiologist, be it the biotechnologist. I am bringing this practical experience because the 2 questions you raised are the core of this. Do we need a national guidelines? If yes, what does it mean? What kind of adaptation will make it to our local level? How much we are going to be committed to the principles that we say we are making as individual practitioners, as an entity, whether it's private sector health facility or a teaching hospitals or a university teaching hospitals. What does it mean to us, these value systems, to believe in the national guidelines? What does it mean in the multidisciplinary that we have some examples here, the radiologists, the nurses, the pharmacists, what does it mean to it? These are the basic questions. I'm sure it goes through your mind. With implementation, Doctor, you raised a very, very, very crucial question. Actually, Dr. Sameh, you raised it. I was just sharing here, we have a lot of beautiful guidelines, and some of them adopted, and I'm talking from my region now. Adopted, shaped, brought WHO experts, sat around the table, did developing the guidelines for clinical care of X and Y, and then it was put in the drawers for various reasons. Once, the availability of diagnostics. Second, the readiness that Dr. Arash was talking about. The readiness of this consultation coming together around the table and share and consult. Today, if we do a quick survey and assessment, very few of us consult. Each one of us believe we know the guidelines, we will adopt it. Rarely we will see success stories that a group of the consultants talked about the cardiac care, with the anesthetist, with a group of specialists on the same specialty, and brought other specialists to be working with them. That's where I see the guideline, national guideline, will be supportive for sharing, caring, more importantly, delineating who is the responsible, and Doctor, I think it was used about the accountability. And it brings accountability, what does it mean for the different roles? That's another discussion. I know it's going on a lot in Egypt about accountability, but now I are talking about why it is important to have these 2 questions throughout the process, that we are talking between today, Thursday, and beyond, because this will continue. It is not just stopping with this workshop. We see you as the core. The two questions raised with the values that we are putting are the core that will be guiding us all for the coming few months. I hope that we can finish. I know Minister wanted this to be 100 years ago. I told him, not yesterday. We are seen slow. However, I'm believing we are not slow, because in this room, we have high experts committed, raising the question, and the question will guide us. And this means put these two questions in our mind, look at it within this, bring why do we want it always, because this will bring, it's not just accepting, right? We see what is on our ground and how we can bring the expertise from different settings to work together to set the national guidelines. I am a believer, because we did it in my small country, very small country, but it made a big difference. It made a big difference in equity, it made a big difference in equality, it made a big difference in the cost, it made a big difference in the outcome of the care, reduction of mortality, reduction of morbidity, because the way we applied the guidelines, including the right use of right technology, including the right use of technology, and the timely use of the technology that Taras was mentioning. It could be middle of the night, it could be. So these are some of the very critical questions raised, some of the elements that we need to consider, because this talks about, if I'm not mistaken, maybe I was thinking that you are also the core that will be continuing teaching others also on how to develop, to finalize in different components of the guidelines. Thank you.
Shukran, Dr. Naima. Okay, so let's have a couple of more quick points because this is an important issue, and our aim is that these principal questions, we address them, all of them today, so that then from tomorrow we can focus on the methods, so that we are on the same place. So one here and one.
Just a question for Dr. Mohammed Soda. I would like to express my gratitude on behalf of all Egyptian nurses about a very important step to improve a clinical guideline. Already we had with cooperation with WHO 10 clinical guidelines related to nurses, but I want to focus or ask you about what about other health team, all dental team, physiotherapists and other paramedics. We need a clinical guideline for each health member to improve health system as a general. Thank you.
Thanks for your questions, but I would like to express my thanks again to His Excellency Dr. Khalid to start this efforts to have clinical guidelines. We discussed with him that we need other specialists, but we brought the physicians and the 10 specialties as a priorities. We will touch the developers, and then we extend to other specialties. So it is in our considerations. But that's the first step, and we didn't move, and we have some resistance, but it's okay. I hope, inshallah, improve.
Shukran. I have 3 more colleagues asking, so here, Dr. Murad, and here. So can I ask you to be brief and quick so that we are behind the agenda and we do it? So any further? So, and one here, so 4. So is that okay? We close it at 4 and then we open it again. So please go ahead.
I just thanks for you for about Egyptian guidelines. It is too late to start now about Egyptian guidelines. For me, as a urologist, I am head of urology department, Sahel Teaching Hospital. Renal stones have a lot of options, from starting flexible retroscope laser up to open. In Egyptian guidelines, it will help a lot of centers and a lot of urologists about the priority. Because if we will follow American or European guidelines, the morbidity or mortality may increasing because of resources, economic, because of surgeon preference and the patient decision, shared decision treatment. So Egyptian guidelines, it's very, very good idea. It is too late to start now, but thanks for all of you to help us. Thanks for Dr. Mohammed Fawzi for helping, and the Minister of Health, Dr. Khalid Al-Ghaffar. Thank you.
Many thanks. Dr. Murad? Dr. Murad?
I'm Mohammed Murad, consultant of Sangaini at GUSI and the project manager. I just want to clarify the idea or the vision of the national program. We are not going to adopt an international guideline because of the availability. Sometimes the international guideline will not fit, especially in many hospitals, not in the university or teaching hospital. We are speaking all over Egypt. In Upper Egypt, some hospitals lack some resources. So even the guideline will give us options to the low resource settings. And we cannot do de novo synthesis of Egyptian guidelines because we have to admit that our research base is still not that strong. So we are speaking about adaptation. And why we need a national program? Because to provide health services of quality, we have to have standardization first. We can't say that some universities will adopt or adapt the British and some will adopt the American, and everyone is taking his own guideline adopted as it is. So I prefer to stress on this, that we have to have a national program for standardization.
Thank you. I'm Saleh Nafi'. I am consultant critical care medicine. And in short words, to solve the conflict or the questions raised by Professor Sameh and Professor Dr. Ahmed Abdelaziz, we need a national guidelines rather than dependent on the international? Yes, we do, but we will do it. We will have a national within the frame of the international guidelines. So the sources of the national guidelines will be the mega trials and the different international guidelines Dr. Sameh referred to. Okay? For example, in 1 second, I'll say if the international recommended guidelines recommend 2 medications for a certain disease to start with, and the same has the same strength and the same benefit and everything. Some of them is expensive or not available here, and the other is less expensive or available. We will choose the least expensive or the available one. This is in short. So we do need a national guidelines, but it will be within the frame of the international guidelines. Thank you.
Thank you, everyone. My name is Wafa Benyamin. I'm a consultant OB-GYN in Maternity Teaching Hospital, and I'm a member of the representative committee for the Royal College of OB-GYN in Egypt. My question is to Professor Mohammed Fawzi and Dr. Naima. After thanking, of course, for this very fruitful, inshallah, workshop, can we dream more and extend this national project to include a parallel working party or working group for Arabic national patient information leaflet linked to every guideline? And the other thing, the national consent form, because of for the interventional procedures, the common interventional procedures, we need a national consent form as well to decrease the litigation. Thank you.
National. I don't know how many in this room have used World Health Organization's clinical protocol guidelines for various, I can think of the especially communicable diseases. We work with the TB. We just adapted for the nationals one. Doctor, you were talking about the international, so you adapted with Dr. معالي الدكتور عوض تاج الدين for the tuberculosis patients and what can be done. We do have for the children care. So there are so many guidelines, and somebody said American, British, I was saying Australian, New Zealand, Japan. It's just how are we going to see what is happening here and how are we going to adapt it? I come from a background, I say it is time that the scientists, and Egypt has lots of scientists, do your guidelines. And then they will say, oh, we have adopted, other countries will say we have adopted Egyptians' models guidelines. I think it's time to shift. Today, with the COVID-19, there was a lot of opportunities of cross-cultural, cross-work between the countries to know what is the best guidelines to protocol for care for the COVID-19 patients and the various, whether they are having heart disease or respiratory or, I'm talking about the burden of disease, the double burden. So to me, this is what I want you to think. The experts here of WHO are actually Nathan Paul and Dr. Arash and others are giving you the principles. It doesn't mean we should not cross the boundaries. Talking about the rights of the patients. Rights of patients is under patient safety, clinical governance, and there are definitely the components of consent. I'm not sure whether you are following now. Recently in our region, there is a lot of discussion about the consent and what should be there and what should not be there and should be part of the care protocol. So that is something that will definitely, the team will be doing it. Information leaflets for patients, there is a lot of education happening. COVID-19 was a great opportunity, and we already mentioned that how it was used to give the information, self-care directly to the persons and to their families. So that's the technology I was talking about. We have a challenge. I know now there is a telemedicine law. We as the World Health Organization with Dr. Arash team and Geneva team, there was a series of workshops done to just start thinking about how the telemedicine should be. What does it mean in terms of responsibility, accountability? What does it mean in terms of having the right protocol and the clinical protocol for the various care or diseases that we want to respond and conditions we want to respond. That means it is a very right forum, right momentum to start all these different components together. And it doesn't mean it is not there. It is there because it is a core. If we look about equity, equality, if we talk about rights to care, if we talk about the accountability, all these 5 pillars or 6 pillars are there, and we just need to bring them together. For example, I was told today we will have Majlis al-Sahhi al-Masri with us. Now, that's a new, I was sharing with the experts early morning, this is a totally new body. صح? It's totally new body. It's a newcomer, but has loads of functions to do. One of the key functions is to make sure efficient care, quality care to every individual in Egypt. And it says individual, it doesn't say only Masriyin. That means, again, you are having inclusiveness, you are bringing the direct care, practitioners, experts, specialists like you have wealth of experiences. I was very pleased when Dr. Ahmed, you mentioned, you initiated with a search and see what is the practices in the country. Just imagine every one of you do the same. In the coming 2 months, what are the practices we are doing for care of just take a disease, obstetric gynecology? How are you handling preeclampsia in your setting and in other settings? And what does it mean? So to me, this is one of the niches. It's a combination. It is not 1, 2, 3, 4, 5. We are having several components that we can build in each other. I would like to stop here. Arash, give me the 3 of you tell me stop, it's not your time.
Well, since you give me the permission, so, obviously with Dr. Naima, she's a senior colleague in the whole of WHO. I know her from many years before I joined WHO. But when I was the same age, but Dr. Naima was much, much younger. So then okay. That's a pleasure to listen to you always. Many thanks. So very short intermission, and then from Professor Paul,
Kamal,
and then we close the session.
National Liver Institute, Professor of Gastroenterology, Teaching Hospital. So, and co-chair or co-manager of the National Guidelines of Egypt. And thank you for all supporters. So I have quickly some points. So we have met with all stakeholders months before, and Arash and all the WHO representatives with us about that, and we have met with all stakeholders in Egypt, including the specialty societies. and Dr. Professor Sameh was the representative of the cardiology, and we all agrees to do an adaptation of the international guideline, one of the international guidelines to be adapted and to be through all scientific processes. The second thing is no one in this meeting, or I think in the stakeholders, accept economic problems that affect the patient interest. For example of the hypertension speaking about Professor Sameh. So, and this will be done through meta-analysis and systemic review and scientific process, and WHO is here to support us in this kind of selection. So thank you.
I just wanted to take the opportunity to pick up on the level of sophistication of care that was mentioned earlier on. So any recommendation is in the context of the expertise, the equipment, and the services available. And of course, in a country where you've got mixed levels of services and you have some procedures that are quite advanced, the recommendation in a setting where it's safe to do it may not be, may completely flip in another setting. So but that means you should be able to build in the requirements from the service in order to implement the intervention. So with echinococcus in managing cysts, you know, the surgical and pair procedures may well not be safe in without appropriate guidance and ultrasound and so on. And so the way it's being approached by this group, or we're pushing them to do it, is that recommendations should be in the context of a certain set of services being there, standards of service, and that you actually specify those services so that that makes sure that the recommendation is both safe and effective. But it may be that those services aren't equally effective and you need another recommendation, another set of circumstances. So I just think there's an important link between the recommendation and the level of the health system at which you're implementing it, and to keep that in mind as you go forward.
Thank you so much, Paul, and thank you, everyone. I would hate to stop this excellent discussion going on, but just in the interest of time, if I can invite Dr. Arash to give his first presentation, then we can take our coffee break and the group photo. In 10 minutes.
Well, I try to do it quickly. Yeah. Okay. Yeah. Okay. Yeah. Many thanks. Okay. I mean, I really enjoyed the discussion. I mean, these are key questions and need to be addressed, need to be raised. Not all of the questions that were raised were related to the first session we listened to. This actually anticipation about the discussion that we are having, which is again great. The main issue in the end is that identify a way forward that works for all the basics requirements that everybody agrees, but also leaves room to the areas that need to be sort of discussed further and sort of according to the circumstances to be decided upon. So, and there are occasions that we, for example, in a certain session, we say, no, this has to be done. Without this, a guideline is not a good guideline. But there are also many occasions that one would say, okay, no, that's the place that you need to discuss, that you need to consider areas to come forward. There are cases that you might also make a recommendation that is really strong, no deviation, but there are cases saying that the evidence does not help me to select which one is the best. These are the options that you choose from. And colleagues who have experience in guideline, they've seen all of that. So those happen in any good program guideline. Okay, now I go to another important issue, the issue related to prioritization. I know Goti has worked on that area, the team has been there, and we discussed this briefly last time, but now it's about moving forward and the issue of just bringing the discussion quickly again. So first of all, I would talk about what is meant by priority setting for a guideline program. So exactly what we are talking about here. Some criteria, review of criteria, we referred to these in November, but I mean we need to refer to them today again. And then some discussion of priority setting process, so very, very briefly. Okay, when we talk of priority setting for a guideline, what we are talking about is that identifying the clinical or public health issues for which a guideline is needed. So obviously, it should be an issue of importance. Let's say I'm worried about management of, cardiac arrest. So at the hospital level or at the sort of, at the community level when the first contact is occurring. So that's the area. That should be a clinical issue. But then you are also a clinical issue for some reason, for some justification, you get to the point that this needs a guideline. And then you prioritize on that, because not all clinical issues or not all public health issues, you ask for a guideline for it. And you have good reason for that. So, and we come to those issue of areas. So that's really important. I'm saying this because I want to highlight when we refer to clinical disciplines, that's not priority setting, unless we get to the point of the issue we are discussing. So we don't talk about, let's say, we need guidelines for nursing care. Of course we need guidelines for nursing care. But if we say we need guidelines on nursing care, who is going to disagree with that? That's not priority setting. Personally, when you say which area of nursing care you are worried about, which element of it, which issues you are focusing on that, or you see that as a package of care or not. So when you get to those levels of a specification, not too detailed, then you are in the level of the right place for priority setting. So at the same time, we will listen later on to the issue of what we call guideline scope, guideline PICOs, that will be practiced there. So I'm not talking about that either. So we don't become that detailed about the process. So it's not about the specific question we are addressing, but the main key issue. I hope I make sense here, but I try to put some examples in the slides. So let's say, if I talk of emergency medicine, that's not a clinical issue. I'm talking about, but then management of COVID patients in ICU, that could be sort of an issue, a clinical issue that could be the topic of a guideline. Guideline for PAC, again, that's needed, but that's not helpful for priority setting, management and referral of COVID patients at PAC clinic, for example, something we referred to earlier. On endocrinology, or even if I talk of diabetes, guideline for diabetes, I mean, it's possible theoretically to have guideline for diabetes, but the disease is so big and so varied, and so, again, even that is not good enough for the topic of a guideline. Then you might have, say, management of gestational diabetes as a topic, or having preventing and clinical and surgical management of diabetes food. That become the topic of your guideline. And then the way that the countries decide how to limit it very much depends on the priorities, the stage of care being provided, the elements of, I mean, Paul used the word equipoise a few times. Equipoise, and it's a difficult English term. I don't know whether everyone knows the meaning of it. Everybody knows? The equipoise is the situation then when you cannot decide. You are in a position you don't know whether to go right or left, which is the best approach. So when you have a question like that, that's the time that if you know something is definitely wrong, the guideline, well, can help you to stamp it, but you already know it. Or if you know exactly what is correct, then guideline is helpful to stamp it, but you already know it. The best use of guideline is when you are not sure. You are not sure is not just you individually, it's actually among you. People disagree with each other. That's where a guideline is the most useful. We get back to that later on as well. So again, mental health, then treatment of depression could be a topic of a guideline, but even that on its own is large. So some program, for example, go treatment of the depression according to the age groups, for example, etc. So when we talk of prioritization, is actually listing these issues, including public health issues. For example, interventions to increase physical activity among adolescents. It's a public health issue, and a public health guideline can help for that. So when you list these areas, and then you select which one of them you want a guideline for, that's where you have a priority setting. So are you asking me for the microphone? Okay, that's good. Yeah, that's right. Okay, so criteria used for priority setting. I'm listing a few here. So prevalence of the clinical problem, burden of the disease, mortality, morbidity, functional impairment, cost of the problem, cost per person, total cost to the society, variability in practice, whether sort of guideline, a potential guideline can change practice, or no, it's a guideline that even if we have a guideline, we cannot do much because it's, for example, something difficult to manage or impossible to manage. Potential for the guideline, professional interest. Sometimes guidelines developed because certain profession groups, they want it, for example, for educational purposes or for development of the sort of the area of work, availability of evidence, etc. So my question to you is that look at the list again and think of which ones you are going to select. Or maybe, in your table for 2 minutes, if you can select 3 of these, just 2 minutes, so quickly please, select 3 of these criteria for selection of, for prioritizing guideline. You have a list of issues similar to what I discussed. You want to prioritize which one should be the first guideline coming forward. I'm also saying that the reason you need to do that is that you cannot have all the guidelines at once. It's not possible, it's not useful, it's not helpful to the country. So you really need to prioritize. That's the rule. Okay. In your tables, please talk to each other. Otherwise, I will be doubtful that you are listening to me or not. So. Okay, so I know it's a short time, but any table wishes to share their thinking with the rest of us? So what 3 areas? Okay, table in the back, so we need. Oh, you have? Please go ahead.
I have one. Thank you so much. I'm Dr. Soha Ahmed. I'm a professor of clinical oncology in Swiss University. For me, I think the potential of guidelines to reduce the costs is very important. And by reducing the cost for the service, we can shift to the other potential, which is improving better health outcome. I want to give a very quick example from my domain, and because I was impressed about the discussion that is running on before your talk. So in the oncology, and particularly for my specialty, which is radiation oncology, I'm a radiation oncologist. So we have, as we said, millions of guidelines and many trials, many streams that we can follow, European, American, Australian, many. So finally, we find ourselves in the area of nowhere when the COVID is here. And surprisingly, no one followed any guideline. And we initiated our own guideline, depending on what's going on, what's upon the circumstances, the availability of the transportation, how can the patient come and go, and the surprise is those guidelines in the radiotherapy is mastering nowadays and running on nowadays in England and in US, and I will recommended it in my practice, which will be initiated in the upcoming 2 months. For example, the breast cancer patients was treated in the course of radiotherapy 5 or 3 if it is hypofractionation, or 5 if there is a colleague of mine here. But nowadays we can just go for only 1 week, 5 fractions, and everything is okay. And we have already data of the radiotherapy follow-up for 2 years, COVID patients, and they are doing great. So we can not adapt, we can just initiate and go further and have a very valued guideline that adapted our resources and our patients.
Okay,
Thank you.
very good. I mean, you raised the issue of sort of the two criteria you would select, and then you gave a good example. So I want the tables to focus on priority setting at this stage. So I have colleague from this table and then back table. So maybe 3 cases will be enough. We can move, and then we open up for discussion again after that. Oh, okay, that's fine. You can actually share also your difference.
Yeah, okay. Good morning, everybody. Thanks for giving us this chance. It's very difficult to answer. I am Amr Yassin, professor of anesthesia intensive care at Mansoura University. It's very difficult to answer this question if you didn't define who are the group who are prioritizing the need for the guidelines. Because if an academic group or a specialist group, like say the Egyptian Society of so-and-so, is determining the priority, definitely will depend on factors like the burden of the disease and variability of the practice. But if the body who is prioritizing the guidelines, definitely if it is a national program or the country officials, it will be based on the prevalence of the clinical problem and the cost effectiveness of the treatment. So
what do you think? The question is, in your table, what do you select?
I selected for myself, I selected the prevalence.
I select variability in practice.
Okay, shukran. So, and then I'll listen to colleagues in the... Shukran. Introduce yourself as well.
I am Dr. Mohammed Omar, head of critical care unit in Minya University and the president of Upper Egypt Critical Care Association. I agree 100% with you that we are in a strong need for this guideline, Egyptian guideline, which must be a modification of the international guideline, as we live in a different environment, exposed to different pollution, receive different nutrition, receive different medications. And we have a lot of topics in our specialty, critical care, like infection in critical care units, like IV fluid therapy, like a correction of electrolyte.
Okay, and then what criteria you use for priority setting? So how do you decide which one of those is the most important?
There is no selective guideline.
I know, but I mean, if you want to select which one to develop now, so if you want to propose to the national body saying that this is the guideline we need to do first, what would be your criteria for priority setting?
I will deal with the international guideline and do some modification according to our area.
Okay, sure.
Yes, thank you. Thank you.
So, excuse me, please. Can I
of course
have a final comment?
Yes.
I'm an associate professor of neurosurgery in Cairo University. I have a different perspective on this. I agree with Dr. Abdulrazak here that the COVID pandemic was the ultimate exposure to a national guideline where nobody had a preformed idea about what to do, and there was like this gold standard that was set up by the state so that you can actually be accountable on whether you adhere to it or not. And this has given rise to a national interest in the development of guidelines. But for me, as a neurosurgeon, the standardization of service and variability of practice is the priority that we should, I assume, we as a surgical specialty should be working on. It's very important to decide who does what and what equipment is needed. The quality of service provided in critical surgeries like neurosurgery needs to be regulated well, and there is a very important medico-legal background that is quite tied to the development of the guidelines, because we are currently developing the medical legal responsibility laws in Egypt, and to be able to develop these laws, we need guidelines so that the laws can actually be implemented, because if you adhere to the guidelines, then you're scot-free. If you fail to do so, then you're accountable. So it's very important to us to develop those and to maintain a standardized service with the least variability possible. Okay. Thank you.
Shukran, and that was an important point. So a quick comment from Paul, and then...
Just to add that Charles Norman once said, it's the size of the solution rather than the size of the problem that's important. So you know, getting the hypertension thresholds right would seem to be quite important to do. The second thing to say is that when new technologies come in, that is a window to appraise carefully before they become fully established. Just to bear that in mind. And the third thing to say is the the grade guidance process separates things from strong recommendations and conditional recommendations, and strong recommendations are things that you really want everybody to do all of the time, and conditional is to be more debate about it in clinical circumstances. And actually that differentiation can help you prioritize your implementation plan.
Okay, many thanks. And again, what is also really good is that we actually link the programs of the few days that you are together. So I mean, we discuss issues about recommendations. That is the whole purpose of a guideline, is the recommendation. It's not the 50-page document, it's actually those few sentences. That's the main purpose of a guideline. And so then we are linking the process together. So I see one hand, so maybe last person in this. Do you have a mic close to you, please?
I am Dr. Amr Mahfouza, consultant for endocrinology, National Institute of Diabetes, and head of endocrine unit and ER unit of my institute. My priority for when manage my patient is the burden of the illness and the cost of this management.
Okay, shukran, very helpful.
Assalamu alaikum. My name is Diyaddin Abdul Mawla, consultant of emergency medicine. We agree to choose the prevalence of the clinical problem, the burden of illness, mortality, morbidity, or functional impairment. And the fifth one, potential of guideline to improve health outcomes.
Many thanks. So let's close this session. We come back to this discussion again. I want to make two comments before I go to the next slide. One is that I'm really fascinated the way it's been planned. I'm thanking Minister of Health. I see colleagues from different cities, and I want to highlight. So I was in Mansoura a couple of years ago, and it was a beautiful city. I'm glad to see someone from Mansoura. And recently I was in Minya, such a marvel of history of Egypt. And I mean, I'm glad to see colleagues coming from all over Egypt here. The second point is that when we are talking about these ones, I just want to highlight, when we are talking about priority setting, of course, if you are within your society or even within your hospital, you might do priority setting for a local guideline or for a society guideline for the areas of interest. So then you might do priority setting there, and you have criteria to do that. But when we talk of national guidelines, the national guidelines, when we do priority setting, should be by the same committee which is multidisciplinary. So that would include all the perspectives, not just perspectives of one group, for example, senior officers in Ministry of Health or senior officers in insurance organization. It includes, as it is now in Egypt, includes representatives from different disciplines, clinical care, but also the policymakers. So all the perspectives together, and then the criteria helps you to make the right decision. Okay, so now the next study is actually, I'm using a sort of two studies. One of them showing that the national agenda that you see different countries that have talked about priorities, and they are not using the same criteria. The people using different criteria, the methodology of applying criteria is very complex from time to time. So it's not an exact science how to do it. So even if we go for the criteria, we need to apply them with conscience and with sort of clear argument to go forward. So the other message in every priority setting is that it's much better to have fewer set of criteria and apply them really well rather than list a long list and then end up not knowing how to make the decision or make a complex, mathematical calculation of adding up numbers and getting there. So in that sense, I mean, this is another systematic review that was published a few years ago. They looked at 10 programs, 10 priority setting programs globally that they have published a priority setting approach. So out of those 10, all of them used health burden. So obviously health burden was something that everybody said, a guideline is a priority if there is a big health burden there. 8 out of 10 was practice variation, and a few of you highlighted the issue of the importance of practice variation. I mean, variation on its own is not a bad thing. We all understand that. But a variation that causes patient discomfort is that I went to Madam Professor and she gave me medicine A, and I went to sort of Sir Professor and he gave me medicine B, or he told me, oh, you don't need medicine. Even if both of them are within the margin of correct practice, as a patient, I will be concerned, and I'd rather to be a national guideline to say that both of them are okay, if both of them are okay, rather than I need to select whether to listen to the gentleman or to the lady. And this happens a lot. But then variation also, a lot of time is about, as Paul was referring to, is about the things that are not correct. They cannot be correct. All of us are clinicians. I can bet many of you in your clinical ward, there are things that your colleagues might do that you thought, well, that wasn't the best thing to do, or the most correct thing to do. You want guideline to try to solve those issues too. And the other issue is that I might be the wrong person. I might think other people are doing the wrong thing, but I might not be giving the right process because I may not have seen it. So in a way, guideline also opens my eyes to my own practice as well to improve further. And then the third one, the impact on health outcomes, then you can see a few fives here. Half of them had done it. So economic burden, Naima referred to equity burden, relevance quite a lot, absence of guidance, et cetera, et cetera. So according to these, I mean, the three minimum that should be used, that we recommend, is health burden, obviously, practice variation, or lack of established policies. That's a good thing. That's a good cause, actually, to bring clinicians together and to see together and disagree. And then, so these are the two minimum. And then the other two, one is economic burden. I know in Egypt has been highlighted quite a lot. And we heard from our colleague from oncology background, and she mentioned that economic burden is really important to me. Why? Because cancer treatment is so expensive. And if you use the wrong medicine that is also expensive, or not medicine that is not needed, and it's also so expensive, then obviously that's quite a lot of burden to remove. But then obviously total cost, the number of patients, etc. Well, in the health economic sections of the workshop, we will cover those. And then potential impact on health outcomes. Whether you expect that it will improve situation. This is the most difficult of these to actually to know in advance, but it could be used as an argument for prioritization. Okay, so then suggested approach. First, I mean, a long list of disease health issues are needed. So that long list should include all the elements that is coming. The long list should be considered. So it's not about disciplines again. That's what we also discussed with Dr. Fauzi last year in November discussion, is that, so when we talk of priority, it's not that priorities within emergency, priorities within endocrinology, priorities within urology. It's actually priorities across all areas together as a national program that you need to look at it. And then identifying the health that are sort of identified with justifiable manner, and then selecting the ones that are most important. So I think I covered all of this. So questions? Yes.
Mohammed Al-Atrabi, Head of Urology Department, Sahel Teaching Hospital, Cairo, Egypt. We can summarize the priority, patient safety with minimal cost. I mean, the patient safety cure the patient or improve quality of life with minimal cost. If we take this equation, we can make Egyptian guidelines according to this. Can we apply this?
So, I mean, patient safety is really important. I mean, there is a big program going on in Egypt right now, the clinical governance. My colleague Riham in WHO and other colleagues who are sitting on that table are working with, on patient safety, clinical governance. That's really important. When we are talking about guidelines, we are talking about recommendations. So do this or do that. And the recommendations are related to management of a public health issue or a clinical issue. So it's clinical clinical practice guidelines or public health guidelines. So in a way, if you're thinking of, for example, part of you may make a recommendation to reduce error. You may make a recommendation to reduce cost. You may make a recommendation that is sort of, you want to remove a safety concern. That within the same package, you make that argument. But you make that argument based on evidence that is available to you, based on the practice and understanding that is known. And you will be very careful when you make those recommendations, so that, because sometimes, certain things become too rigid and too restrictive and may not be really helpful. At the same time, some basic principle might be missed easily. So I don't want to go to that discussion, because in a way, the selection criteria here starts from the evidence. And that's the discussion we are going to have from tomorrow onward. So the evidence is your judgment on make that decision. But the principle you are saying, yes, absolutely, that's one of the key principles.
Thank you.
Okay, so tamam, yeah? For now? Okay, let's go for the break, yeah? Yes, please. Kam daqiqa, inshallah.
Thank you so much, Dr. Arash. I mean, we're already about 45 minutes late, but I'd like to invite you to a very quick coffee break, please. We were supposed to have the group photo now during the break, but WR had to leave for another meeting, and she'll be back in the afternoon. So around 2:30, we'll do, inshallah, the group photo. So if you can please help yourself to a quick movement break and some coffee. It's in this direction now. It's in the foyer here. Thank you so much. Can we be back in 15 minutes? So can I say 11:50, please? 11:50. Thank you so much. مساء الخير يا جماعة. لو نقدر نرجع علشان just a few points كده that I wanted to clarify, please. فيعني لو في ناس بره لو ممكن يدخلوا لو سمحتوا. أولاً إحنا هنعمل registration، يا إما هنمرر ورقة عايزين الاسم بالإنجليش يبقى مظبوط علشان السيرتيفيكتس. فيعني أنا طبعاً عندي list of participants كلها، يعني أسماء حضراتكم موجودة معانا، بس just to ensure إنه الأسماء مكتوبة بطريقة مظبوطة. I would like بعد إذنكم لو سمحتوا إن أنتوا يعني كل واحد يكتب اسمه أو يأكد إن هو مكتوب بطريقة صح. النقطة الثانية that I wanted to clarify، لأنه يعني يبدو إنه لما في حصل ترشيحات ما كانش واضح للكل السبب بتاع الترشيح، أو ما كانش واضح إحنا هنعمل إيه أو هيكون متوقع مننا إيه. إحنا النهاردة we are doing the first training of trainers. You are the main batch that has been selected to take a big part in the committees that will later be formed for the development of the national clinical guidelines. This has been based on the selection criteria وده ترشيحات رسمية. It is very important إن احنا نبقى عارفين this is not an isolated meeting. This is not just a meeting that we will be attending for information وخلاص. This is going to be continued later on, and there will be methods of communication. حضراتكم, you are going to be our main nucleus, our main focus of clinicians and multidisciplinary teams that are going to be involved in the review committees for the different specialties. فيهمني جدا ان حضراتكم تبقوا عارفين، او لو في حد عنده سؤال. انا برضو دكتور محمد فوزي هيكون معانا حالا، يمكن كان موجود بره. لو في حد عنده اي استفسار please let us know. It's really important that it will be clear what the purpose is of today. يعني any questions in that regard، أو عربي أو إنجليزي مش مشكلة. فحضراتكم هتكونوا معانا. You have been selected as the main bulk of trainers. Later on we will need your help in guideline review. We will need your help in the different drafting of the different guidelines. We will need your help in you will actually دكتور محمد كان بيsuggest ان احنا يبقى في visit، لان احنا عندنا دلوقتي National Clinical Guidelines Center في سنتر معمول مخصص للناشونال كلينيكال جايد لاينز في مستشفى المطريه التعليمي. فإن شاء الله there will be a follow-up to visit the National Clinical Guidelines Center. You are going to be our core team that will be initiating this process of guidelines development. So we will be referring to you several times. ده غير طبعا هيكون في شهادات to indicate your participation. لو في أي حد عنده أي سؤال أهلا وسهلا بيكم، ودكتور محمد فوزي موجود برضو if you'd like to. حالا الأسماء هيجي لحضرتك شيت عشان الأسماء حالا. Thank you, Dr.
Shukran, Yariha. So, I mean, in terms of the process, obviously, there will be functions, different roles colleagues play. It's also in the importance of expanding national capacity, so that will be done through you. So let's go to the questions, the session that is very much related to the discussion we had earlier, raised by Professor Hossam, and also other colleagues referred to that. So the issue of adaptation, adoption, and related approaches that we should be followed. Okay, well, I mean, first of all, let's quickly refer to some words. I mean, these words are used even in the English language with some leniency. Sometimes people mean different things by them. But then when they are translated to, let's say, Arabic, then also the translation may not match. So the difference might leave itself. So let's agree on one key term is adoption. You know, we talk about child adoption, so someone accepts a child as their own child. Adoption of guideline is that you accept a guideline as your own guideline. So by that, it's a decision. So adoption is not, well, this is a good guideline. That's not adoption. Adoption is that this is a guideline, I assessed, I agree with it, and I accepted this is a guideline. If I wanted to do, it would have been my guideline. That's called adoption. So in a way, adoption is linked with implementation. You don't adopt a child and then leave them on the street. When you adopt a child, you need to pay for it, you need to raise it, you need to care for it. That's the sort of, I mean, it's an explicit decision, so that's important. So some of the issues I will refer to later on in my short presentation, make it more clear. The other thing is adaptation. Adapting, so you change it for your context. These two could be also linked to each other. I mean, there are obviously a spectrum of decisions that the team make, but very clearly when we talk about adaptation is that you identify a guideline, the guideline seems to be useful. If it's a guideline that you don't like it, then you don't adapt that one. It's a guideline that you cannot trust, you don't adapt it. So it's a guideline that you have accepted, that it has the basics issues that you need. Some of you who were in November meeting that we had, the workshop, so you remember I made an example. So adaptation is about you want something for a purpose, but then it needs a bit of change. So let's say, I mean, nowadays the need for such a thing is much less, but I mean previously, so let's say you want to buy a dress, and the dress is really beautiful, matching everything, the price is perfect, etc. But it's a bit, not the correct size. You buy it and then you adapt it to your size. That's adaptation. But then you might also add a little bit, I add also something on the sort of on the chest, and I add a flower at the bottom of the skirt or whatever, or the trouser, whatever. So I don't want to just make it as the lady's choice, but men's also do. I mean, you buy a trouser that you like, is on sort of on promotion, and then you go to the sort of the khayat next to you, and then you ask for the size to be changed. So that's adaptation. That's what we call about adaptation. But then you do that based on principles. You don't go there and say, well, can you change it? You don't do that. You don't sit in your room saying that I want it changed. You bring someone to measure you, and that measurement becomes the basis. If you do all those things and you make it something that fits you, responds to your needs, that's adaptation. De novo production is, I mean, like you buy the garment and you give it to someone to make it a trousers or a shirt for you. So then you do everything. In the methods that we are discussing from tomorrow, and some of the discussion we had today, we will be talking about methods that can be applicable to de novo synthesis when you start. They are used in de novo synthesis. Not every detailed method will be described, but the main ones are described very well. But then these are the same methods that you use them, because it's like sewing. When you want to make a trouser, you need to know how to sew. But when you want to make correction, you also need to apply that. You can't not to be aware of that and then having your trouser fitting you. It doesn't work like that. You really need to be able to do that. So then the same methods will be applicable, but as we do in case of buying a garment and having a trouser, or buying a sort of piece of trousers and then adjusting it to your size, the amount of effort you do in the latter is much less. So it's more cost effective. If you select the right set of trousers, if the trouser is the one that is going to help you, then you are saving time, you are saving resources, and you do a good job. So that's the link between. So adoption is a decision. It's not just saying that, wow, it's a good guideline, I like it. Or saying that, well, International Diabetics Federation, they have a new guideline, it's so good. That's not adoption. The adoption is that the clinicians together, we sit together, we review it. In my hospital, we decided we are going to follow it. That's called adoption, when you make that decision. Okay, so this is in terms of terminology. Any question here? Yes.
If we go for de novo development, if I understand right, we should depend on the systematic reviews. We go to the evidence. Can we go for other guidelines and start to make a new guideline, like many guidelines, many different guidelines, and go for a de novo, or this is a kind of adoption?
Yeah, any combination is possible. So first of all, good national programs of guidelines. Let's talk of a program like NICE that people in Egypt know them very well, because there has been a national agenda to adapt some of the NICE guidelines to the context in the country before. Any good program, when you start working with the new guideline, the first thing you do is checking, is there a good guideline already there? And if you find a guideline that is really good, I remember many years ago, NICE was developing a guideline for management of asthma. And then they announced it as a priority. And then they said, well, we are not going to issue it because there is a British Thoracic Society guideline for asthma, which is really good. So we are not going, so we are waiting for the expiry time of this guideline until we go for the next guideline. So even if you have so NICE is not about adaptation. They never talk of adaptation. But in every guideline that is produced, when they do search for evidence, one of the searches is also focused on existing guideline. You want to use any experience that people have had before you. So you do, that's part of your process. So then, it's also the other issue. When we talk of adaptation itself, again, the issue is that sort of, sometimes you need to look at new evidence as well. I'll refer to that in a few seconds. So there are cases that adaptation itself is also requires checking evidence, especially when it related to local evidence, when we are talking, the evidence coming from Egypt. Rather. Yes?
Some international guidelines claim that they are including experts, researchers from all over the world. So this is an international guideline. So should be applied all over the world, everywhere, Africa, Asia, Europe, States, because they include experts from all over the world. Despite, we understand that there is a lot of differences regarding the training of our doctors, regarding the facilities of our institutes, regarding the culture of our patients. So how to confess, or how to make them understand the difference between our communities and the international consensus.
I mean, that's possible, and that happens, I know. The point is, let's say if you have a proper, I would say, well-done international guideline, how many Egyptians do you expect to be in that guideline? Maximum one. So I mean, that's the best scenario, because not all, even if you have all nationalities, it is too big for a guideline to be developed. So in a way, the best scenario, there will be one person from Egypt, and that one person, how many disciplines that person can represent. Even if you think of that is covering your country, it cannot cover all the perspectives. The other issue is that when international guidelines are done, you actually think of international context. You think the same logic. You say, I want to develop a guideline that is useful not to a given country, but also to more countries. So there could be recommendations in it that are not applicable to certain countries, because that was not the intention. There could be also recommendations that have become watered down a bit so that they become more applicable to that average country that is the focus of country. So international guidelines, like any other guideline, are subject to adaptation if needed. But you make that decision after you've done your assessment. It's like going to the shop, you select a beautiful shirt, you say, I want it, what is the price? They say, well, don't worry about the price. I mean, like Egypt, they never tell you the price first. They say, you test it first and then we negotiate. So you test it. If the shirt is suitable for you and you like it, you say, well, that's perfect. I don't mind whether it's been built in Indonesia or in Thailand or coming from Italy. So it doesn't matter. I use it. If I need to change it, I'll also change it. The same applies here. The same is whether it's international or not, the principles apply. But then if it's a reputable international body, you trust it more, of course. You start with a positive note on that. You are sort of, if they say we've done this, you say, yeah, I know. If they say we've done it, they've done it. While a guideline that you don't know from where they are coming, even if they say we've done the search, you say, well, I mean, they say they've done the search, but how can I be sure? And then you probably always start from reputable organizations when you want to adapt something, because you don't want to be going and checking the organization performance itself as well. That doesn't add any value to it. Okay. Now I'm realizing I'm becoming a shopping expert. I'm making so many examples there. Anyhow. Okay, so let's think of scenarios. I try to, with some scenarios. Yes, madam? Close it. I think both of them, they are talking about me. So I think the issue is that both are. Is it better now? Better now? Yes. Okay. Now the reason was because both of them were on, so the voice was being. Apologies for that. So do you want me to repeat? Or?
Just the last part.
Oh. It was about shopping. So that was interesting. No.
I had no clue what it was about. I couldn't hear it.
No, I'm joking. No, the point is, what I said was that, so the issue of sort of try to put some simple scenarios, and with each scenario we just look at it, what we discuss, and go through it, and then we go to the adaptation. So scenario one, adoption of a guideline for use in the country. So you want to decide, this is the shirt I like to use. It could be, the guideline could be from any other source. Could be an international organization, could be another country program coming. So the source could be also a society within your own country. So the Cardiac Society of Egypt might have developed a guideline. This is the guideline of the Cardiac Society of Egypt. That's virtue is, it has some national perspective anyhow, because it's a national society. But if you have a national program, that society guideline is not a national guideline unless the national program also considered it. Why? Because the national program is not just the Cardiac Society, it's actually other societies as well, the general physicians, nurses, Ministry of Health, insurance organization. So in a way, a guideline that is also developed nationally could also be subject to this decision. Is that a guideline that I can actually sign it as a sort of Ministry of Health or the healthcare system as a whole as a guideline? So what would you do? I hope I say your name correctly, Professor Hussam, yes? Yes, Sama. Okay, Professor Sama, apologies for that. So Professor Sama, so he comes as the president of, I know you said you are former president, but he's come as the president of the society. They say the society have done a marvelous job. We've invested so much time. We knew the problem. We developed a guideline. They bring it to you. You are the national committee members. What would you do to decide whether that's a good guideline or not? You say, I know Professor Sama. He's an excellent guy, reliable, and he has an excellent team. I sign it off, or you do something else. Don't think of him. I know if he brings it to you, you sign it up. So I'm talking about as a case. Yes, Professor Murad. You check it. Basically, you appraise it. Absolutely. You check it. Because it's not about knowing the person or not. It's about having to show that the system is transparent and it has a methodology and a process that follows. You do the check.
second thing that we have heard a lot from the societies of specialty about, we have a lot of guidelines, we have spent many years in the guidelines, but the methodology is something different. So we can adapt this and read this again, once again, and can be this coming through the methodology of the WHO perspectives or not for the guideline project. So this is not debatable.
Yeah, absolutely. And it doesn't mean that everyone who came with any document and they called it a guideline, then you have to spend hours to show it's not a guideline. Sometimes you know the methodology, you look at the report, you say, well, this is not a guideline. And so in a way, not everything will be subject. What I'm talking about is something that has the minimums of a guideline. It has sort of done properly, at least, I mean, the way that you look at it. And you know, for example, the process has been followed, you do that. Otherwise, I mean, we had some discussion with Dr. Fauzi before. We were looking at some examples, so, and the issue was that, well, this example is a protocol that is good for procedures in a hospital, but it's not a guideline. So then obviously you put it aside. That doesn't even need to be subject to assessments you are talking about.
I think it would rather be a recommendation rather than guidelines. It's the recommendation of such a society that will enter in the big pool of the evidence-based medicine to get
Well, the point is, I don't know. I don't know whether colleagues Nathan, Paul, Mehrnaz, Edis, others. I mean, do you agree with me or not? I'm a simple man. To me, a guideline is nothing other than recommendations. Everything else is just to support the recommendations. So the guideline is the recommendation. So you cannot select a recommendation and say, I like it or I approve it without accepting the body behind it. So in a way, it becomes the same thing. So, yes, Paul.
Just to another perspective on it. There is a process, pardon? A process of internalizing the recommendations within a group of people that are implementing it. So, you know, as an individual clinician or small group of clinicians, you may say, well, that seems about right from an American set of guidelines. But if you're dealing with big issues that involve resources in a large group of people, a national guideline is a way of the country, of the specialists in the country, looking again at the evidence underpinning the recommendation, unpicking it, and then considering the evidence to decision-making process, which is a separate process, as I explained earlier on. So this, I can give examples of this, not in a level of sophistication as in Egypt, but so in Ghana, for example, WHO had recommended zinc supplementation be given with oral rehydration fluids in children. WHO had recommended it for the whole of Africa. And the Ghana, we worked with the government in Ghana with the Essential Medicines Program, and they went back and they looked at the systematic review on which this was based. And they went through and looked at the countries, and they noted that the weight of evidence was from 2 large trials in Bangladesh. There was a couple of small trials from countries in Africa, but they were really quite small. And they said, well, now let's have a look at the level of zinc deficiency in Bangladesh, where these 2 big trials came from. And they looked at zinc deficiency studies within their own country. And they said zinc is, we've got plenty in the diet, and we don't have the evidence of zinc deficiency in our own country, whereas in Bangladesh it clearly is the case. WHO has recommended it globally. We are going to change our grading of the evidence on directness of the systematic review evidence. They downgraded it quite a lot, and they considered it, and they decided against this recommendation. So it may be outside of some of your specialist spheres, but it's a simple example, and I have other examples like that, where you go back and unpick both the evidence in the process of internalizing it for the country, and the evidence to decision-making framework and may change the recommendation.
And this is an example of adaptation. You have a guideline from an organization you trust, WHO. You start from the position of, I really want to use it, but I want to see how useful it is for me. You look at the evidence behind it, you change a recommendation, and you know why you have done it, what has been your source of evidence, why you challenge the recommendation, and this is what we call adaptation. Adaptation is not, let's sit together and review it together. Oh, we don't have this medicine, let's remove that. Oh, we have this medicine, let's keep it. Or, I mean, oh, nurses in our country cannot do this. Their nurses is much better, or much better, they do that. I mean, or I cannot trust, I mean, sort of the cleanness of my, these are, I say that based on real examples of discussions that you see among clinicians. That's not the process of adaptation we call. The process of adaptation is systematic approach, like the example that Paul gave. Okay, so when that guideline comes, the first thing is that you need to make sure that it's actually for you. You are a gentleman, you need a shirt to go to a meeting, so it should be something useful for you. Addressing the clinical issue you have is related to that, ensuring that it's using valid approaches. For that, you need to do appraisal, you do the sort of processes, and then tools like Agree-to, which we will cover as part of this workshop as well, how to use Agree-to. And when Agree-to is done properly in the context of a specific question, the kind of things that you need to check to say, well, this is fine, is the kind of example that Paul mentioned right now. I mean, the issue of that, whether the evidence behind it is supportive or not. Okay, scenario 2. There is no existing guideline. Then what we do is that, and well, to this scenario also, this is attached that there is a guideline coming to you. You identify an international guideline, or you search for something, or a national one, but you check it, the assessment, well, you cannot trust it. It's not a good guideline. Either it doesn't address your problem, or it does not sort of successfully pass the test you are giving, so that basically you do not have a guideline. Then obviously you go for de novo development. So I agree fully with Professor Murad. I agree fully with Professor Fauzi that Egypt focus is on adaptation of guidelines. But even if you say that's my national agenda, there will be areas that there is no guideline to adapt. But it's a priority for the country. If it's a priority for the country, a major issue for the country, that needs to be addressed by a guideline. If there is no guideline, you need to do de novo development. So even if you say my focus is on de novo, on adaptation, de novo development of guideline is one of the options you need to deal with. As the opposite example I gave earlier in response to your question, even in a country that the focus is on de novo development, they always start by looking at whether there is something that would justify the need for a new guideline or not. Okay, well then there is a scenario 3 is the adaptation issue. So there is an existing guideline. Well, it's good. It looks correct, but it has missings there. I'm not sure. I need to check. I need to adapt, etc. So what are the arguments for adaptation? I don't need to explain this. You said it earlier since the morning very clearly. There is a time issue. There is a technical capacity issue. Technical capacity issue is not about, well, we don't know. Is that even if you know, and if you have 20 people who know it really, really well, how many guidelines they can deal with in a given year would be limited. So in every context, the technical capacity is about how to use your resources the best. The issue could be sort of the disease profile difference between countries. So it's coming from another context. In that context, the situation is different. The case of, zinc deficiency in Bangladesh and Ghana, that's a beautiful example from a real case of sort of a guideline that has been developed and has been adapted to another context. And availability of resources. Availability of resources is not just about money. So there are certain countries in which you have many pharmacists by trading. I think Egypt is one of them. Probably Egypt has more than sort of a standard average of number of pharmacists. Then obviously if a guideline implementation requires extensive use of pharmacists' time, it's affordable in Egypt because you have a staff. There are countries that they are actually in shortage of pharmacists. The same guideline, well, you need to think of, well, should I give it to a pharmacist or I can ask someone else to do that because I do not have enough pharmacists. So resource is not just about money, it's about human resource. Let's think of whether you have a good referral system in place and a country that doesn't have a good referral system in place. Think of a country that has well-distributed, clinics all over the country, in a country that has limitation in that. So all those issues of resources affect the way that a guideline is going to be applied to the context of the country. And these are the questions that you explicitly think about. You sit down and think about them, bring the argument, bring example. That's why you need multidisciplinary team. That's why it's not people only from Cairo or maybe Cairo plus Alex sitting together. You need other parts of the country to be part of the process. Why adapt? Obviously, it's more cost effective, and guideline development is resource intensive. It takes time, it takes money, and how to adapt. Then the how to adapt is the main question. So the minimum process. As I said, from tomorrow when we talk of methods, these are methods that will be used for de novo development. The same methods will be selected from and be applied to adaptation. You need to know how to develop a guideline. You need to be a good hayat to be able to adapt. If you are not a good hayat, adaptation also is not going to be a good job. So you need to know that, and then so you apply it well. Okay, so a simple approach, these 7 steps that I'm going to just briefly mention them, this is not coming from a textbook. This is based on, I would say, experience of several years that we have had. And then we recently, so my colleagues, Mehnaz and Malika, they looked at international methodologies for adaptation. Basically, these are what they summarize. There are some advanced, very detailed techniques for adaptation. So for example, development, the former adaptive we had, different approaches coming. They are very complicated, they are difficult to communicate. This is also a good way of communicating. Then you can apply whatever tool you need into the process. So the first thing is that, the first 2 steps go together usually. So you have your clinical issue. So let's say you are thinking of management of heart stroke in a hospital. This is one of the priorities that Egypt has identified already. So that's the area. So what are the key questions you want to answer? Which population are you going to look at? Any age group? Are you looking at specific age groups? Are you looking at a sort of, let's say, comorbidities or not? Whether it's whatever. Are you thinking of a patient that is arriving in a sort of hospital and the management or after admission to CCU or whatever? You identify those areas, what you are going to cover in the guideline and what you are not going to. That's the scope. Nathan will tell us much more about this in later sessions. Identify the questions. You need a guideline development team. The reason I say they go together is that the guideline development team actually helps you to make the scope more accurate, better. They help you to refine your questions. So as a decision maker, you identify what are the needs, but then the experts sit and tell you, well, we need to define it like this. The needs are more specific like that. When we talk of guideline development group, so let's say we are having a guideline for heart stroke, for cardiac attack, myocardial infarction, whatever we call it. And then we want to have a guideline development group. So obviously you need cardiologists in the panel, that's for sure. Who else do you need in the panel, in the guideline development team? Paramedics, for example, you need nurses there. Why? Because nurses are involved in caring for the patients. Who else do we need? Cardiac surgeons, because they are part of the process if certain complications happen. You need people who know the methodology, they can help the methodology, the process, experts in methodology. Who else? Emergency medicine, ambulance department, public health professionals. Infection control for MI, probably, it's relevant to everything, but you may list a longer list. So then I would say general physician or family physician. You need to think of also maybe for example, if laboratory reading might become an issue, you may need a lab specialist. You may need clinical pharmacists. You may need to have, yeah, absolutely. So, but then you list everyone that is relevant. There are expertise that are very clearly relevant. You tick them. There are expertise that are less or relevant only certain aspects of it. Then obviously you need few cardiologists there. But it's not only cardiologists sitting together. You need to think of each other people, groups are sitting together, they help each other in interpretation, different levels of care. And then as part of your plan, you also decide, when to consult who and where. And then when you think is that you really need, so I remember I was doing a workshop for guideline development in my country, Iran, about 15 years ago. And we were talking about, so there was a guideline and they were sort of working on it, and I said it should be multidisciplinary. And then the nurses are needed there, a real case. And then I said, well, do you have any nurse in your guideline? It was sort of, it was a work, they were doing the job at the center. Yes, we have. And they introduced a lady professor from Tehran University there, professor of nursing. I said, she's an expert in nursing, but does she really do care of nursing now at the moment? She's not only teaching. So when we talk of multidiscipline, are people who are involved in the care. When we say a nurse that is caring, not the best knowledgeable, not the guru of nursing in the country that you refer to with your all questions. Someone who knows how to manage and dealing with that. The same applies to cardiologists, the same applies to sort of lab technician, any group. These are people who do the service, and they do it in real setting. So that's what we are doing. It's not about titles, it's not about disciplines. It's actually representation of the areas of need that are needed. Okay, the third step is that, you look for clinical guidelines. Obviously, as WHO, we say, if there is a WHO guideline, don't miss it. WHO takes it really seriously. We listened to Nathan earlier. I'm very proud to be serving on that committee of the WHO as part of the sort of the work. And WHO takes it really, really seriously for any guideline that comes. So if there is a WHO guideline, make sure you look at it. But then there are other sources. So there is a TRIP database that is easy to search, but there are, colleagues will share with you different approaches of searching for guidelines. You go through them and then you identify what guideline exists. Appraising the guidelines, we recommend use of Agri2. That's a recommendation because it's the best tool available globally. It's easy to use. It's easy to work with it. It doesn't need you to be an epidemiologist to apply it. It actually helps you to go through the process easily. So then and when you appraise, it's not just about validity and technical aspects, it's actually whether it fits the size, whether it answers your need, whether it's relevant to your context. These are the questions that you also address. Then, when you are assessing, you say it's really good, but I need something else. I already have 5 PICO questions. I know Paul likes a smaller number of PICOs. But then, so I have 5 PICO questions. This is addressing 3 of my PICOs. It's better? Wow. Ladies in the back, and also gentlemen in the back, I'm apologizing again. So now I'm realizing it was really weak. So you couldn't hear by now? Oh, okay, very good. So maybe I don't need to shout anymore, so I can be more relaxed. But anyhow, so then you realize there are certain elements that are missing. So 3 PICO questions have been addressed. One of the questions, shwaya, is not completely covered. And another question, it hasn't addressed at all. So then you need to look at updating evidence for those, because those are your needs. You can't say, well, the guideline didn't answer those 3, that's fine, those 2, we leave it there. If that question was a real need for your country, you need to address it. The other thing you realize is that this guideline was issued now 2023. The guideline was issued in 2021. When you do the assessment, you see that the latest search of evidence they did was in 2019. So there is 4 years gap between the evidence they use in the guideline by the time you are doing the adaptation. You do a quick check of the context. You would also like to see whether there is any study from research from Egypt that is good quality that could be applicable. So you do also a check of the context that you have. And then if you have a good national plan, you can do these things really well. Because then there is one search specialist there. You just give them the question. In 2 days, they give you the list. If you don't have that, then it's difficult. If it's become the clinician team to do that, everything like this requires expertise. That's why a national program is really important, because you generate those capacities to do that for you. And then obviously you work on updating and rewriting recommendation. That's the things that we will discuss later on. I mean, the issue of looking at the evidence to decision framework, the text of recommendation, those general. And then lastly is that every sort of guideline without thinking of implementation is incomplete. Some of you refer to the issue of the needs for pamphlet. The example you get, a pamphlet in Arabic language for the public, that's beautiful. I mean, if you do a guideline that is only useful to the doctors, it's good, but it's not addressing everything. So you really need to think of what goes with it, what is the package that will help implementation, different groups that you have sort of as your audience. And so these are the steps you do. So in a way, the steps are more or less covering everything you do for a de novo approach, but in a way you are relying on existing knowledge. You stand on the shoulder of others, and that gets you where you want much faster and easier. Okay, any questions? Yes, sir.
Again, thank you for this nice presentation. I have an ethical concern here about rewriting the recommendation. If we are rewriting the recommendation for the national interest, we are changing the strengths of the evidence. For example, if the international guidelines say that there is 2 options for treating this patient, one of them is a strong recommendation, the other is a weaker recommendation, but for cost effectiveness in my country, for financial limitations, we will adopt the weaker recommendation. While we are rewriting, are we writing it to be a strong recommendation in our national guidelines, or we will state it as a second choice also, but we are adopting it for non-medical causes or non-academic causes?
I mean, the basic principle is that you remain honest and transparent. That's the basic principle. You want to be, why national programs are important? One of the main things is reputation. As a clinician, don't think of yourself as the lead person. Think of the sort of average clinician. You are not going to check everything. You say, Professor Murad said this is good thing. I trust Professor Murad. I do that. Reputation works a lot, and the same applies to reputation of your guideline program. So the guideline program, first of all, should be honest. If they go for something because of the cost, they make it very clear it's because of the cost in the process. So it's not, you don't repackage it to not make it. So and it wouldn't work. It might work for 2 months, 3 months, and everybody would get that. I mean, so when you have people analyze, they come back with you with the same questions that you raised. But the point is, I mean, in the evidence to decision framework and the grade tables we are going to discuss in the workshop, these are the things you actually put forward. These are the things you sort of identify the elements, you look at the source of evidence, the relevance of the evidence, the validity of the evidence, but also the issues of the context that you have in your country. But then you end up in a situation in which the evidence says do A, you cannot do A now at the moment, or you cannot do it in 90% or 80% of your resources. But if A is absolutely important, why do you do guideline? To make the health outcomes better. If A is really important for that, then you make a case to the Ministry of Health. You say we cannot do it now, we realize it cannot be done, but we are, look at what happened in Egypt for hepatitis C. I mean, the beautiful example of success. Why? Because that was a major, major problem in the country. The government became convinced that is a major problem. WHO was happy to support, honored to support that process. And then everybody came on board, and it was done. Not everything becomes like the hepatitis C case, of course. But then you make that case. You say, this This is not possible, but then this is highly recommended. This is what we should do. At the moment, for example, while we are waiting for that, then the best solution is to do this, and then you identify something like that. Paul, do you want to add anything?
I can give a good example of that from Ghana, where WHO had recommended artesunate over quinine for severe malaria. Egypt, you've got rid of it, so it's less of a problem here. But there was a 40% reduction in mortality with this new drug. It was a strong recommendation out of WHO, and the clinicians were on hillsides screaming that this needed to be implemented everywhere. Ghana looked at this and said, well, actually, we've got malaria, but we don't actually have many deaths from malaria. So they plugged the number of deaths the death rate, the fatality rate, in with the relative risk of 0.62. And I think they worked out if they introduced it tomorrow throughout the country, they'd perhaps save 50 or 60 lives, which is not, which are important number of children, but it wasn't as huge numerically as they thought. The second thing they said was it has to be given intravenously, and at the moment people are using IM quinine. We're going to have to equip the nurses, we're going to have to train nurses. Putting IVs up on people that are in coma has its own risks of overhydration, so they considered that. They also considered that they had quality assured supplies of quinine, but not of artesunate. So they said, we know this is a strong recommendation coming out of WHO, but we're going to put this on pause for a couple of years until we've got quality assurance and have a program, a supply assured, and a program to roll it out.
Okay, so Magdi and then you. So.
Thank you very much. Actually, I would like to emphasize on the importance of treatment protocols. That is coming number 7 in the list that you have shown us. Because I believe at the end of the day, in our practice, in our everyday practice, it's the protocol that will be used. And all the examples that was given on the importance of guidelines and how guidelines could change the practice and could lead to better outcomes are examples on protocols, not on guidelines, because guidelines are in one specialty. There are how many topics, how many diseases. Each guideline for a disease is like 50 to 80 pages of text. So we have tons of I would say, the clinical guidelines are reference, material, guidance, but what is really used for everyday practice is the protocol, is the implementation tool, the extract that I would be using for priority interventions that I need to do in a very concise way that leads to really, that I can measure and I can really improve care using it. Thank you.
Absolutely. So let me reflect. I think that was a very important point. So the main thing, why do you do guidelines? You want to change something. That's the main purpose. You don't do it. You don't do guideline for guideline. I mean, well, of course. I mean, you can do guidelines for education. Guidelines have side benefits. For example, for junior nurses, junior doctors, they can be much easier to communicate. It can actually help you in terms of some legal issues in certain cases. But the main purpose is changing. And the tools for implementation are the most important. If you do a guideline and then leave it there, you haven't done the job completely. I mean, when I was listening to Dr. Magdi, I was thinking of the example of, so let's say, I mean, now it's a bit old recommendation, but the recommendation of that every patient that is discharged from CCU with a correct diagnosis of MI, so usually, I mean, you have suspect cases, you admit them, but then some of them, they are proved that they are not correct, and then you release them. Anyone who has had approved case of MI, discharged from CCU, should leave with a sort of prescription of statins. So unless contraindicated. So that's the recommendation. That's the guideline recommendation. This is an easy thing to say, but I mean, if you make it a protocol, it's so easy to do that. So let's say you say the patient, I mean, the internal hospital, that's the recommendation. The internal protocol in the hospital becomes that, because, I mean, I don't know how it works in Egypt, but if anyone who is dismissed or discharged from hospital, they need to go to the pharmacy to get the clearance of the pharmacy and refill, and you say in the pharmacy it cannot be issued unless a statin is part of the prescription, unless doctor has explicitly written this patient should not be given statins because of this contraindication. So then your junior resident is not going to forget. The nurse is not going to forget. Yourself among the busy time, because there is a process, and that becomes your protocol for practice. In a way, so it's the protocol of implementation. The same that why nursing protocols are so beautiful and so well followed. I mean, you talk to nurses, they say, well, doctors, they do whatever they want. Nurses, we know what to do. Why? Because everything has a protocol. You do this and you do it like this, and then you do that after that, and you do after that. It doesn't mean that error doesn't happen in nursing. It does happen there as well. But the protocols help it much, much better. And then that's part of the process to go. So I have one comment here and then.
First of all, I perceived your answer for my question, and Dr. Paul also, but I'm still stressing on the point because I'm afraid that within 2 to 3 months, this group might be into real action, and within 9 months there will be a document labeled Egyptian recommendation or guidelines for Kaza, and have these 2 logos. For my case, what I'm asking about the final draft of the Egyptian recommendation of option of disease B. We're changing the recommendation from the international because we don't afford the drug A into the drug B. In our final recommendation or Egyptian guidelines, will we refer in the document in a written form that the international recommendation is so, but the second recommendation for our Egyptian guidelines is so, or we will ignore the original source, which is, because I think most of our work will be adaptation rather than creation of the Nobu guidelines. Or we will say the recommendation, the Egyptian recommendation is using drug B. By this way, we are downgrading the medical practice in Egypt in a formal, official way.
Well, I mean, first of all, I want, with permission, I want to say a joke first. I mean, the case you said is that, you know, you go to a friend, and then suddenly they bring you a beautiful meal, and you say, wow, so many thanks, you're so considerate. Yeah, I prepared it for another friend. They didn't show up. I'm offering it to you. So you are saying that the national guideline do it like that, so I couldn't do that, now I'm good. In a way, you are actually, I wouldn't recommend that. I would recommend that if the national authority gets to drug B, they should only recommend drug B. But in the background, they explain the justification. You don't want to give the feeling of that this is not done. First of all, I mean, there are many cases. So when we listen to this sort of during the course, the discussion of the workshop, the issue is that sometimes the difference between drug A and drug B is not cost effective for many standards that you consider. So there are even evidence-based arguments that are not related to having enough money in your pocket that you may actually go for drug B. Not every international guideline, I mean, face it, many American guidelines, they actually recommend recommendations that are not cost-effective at all. And they are in a context that is not, the cost-effectiveness is not a major part of many of the players because of the role of the private sector that has there. But even if you get to the point you say, well, I really wish that we had drug A, but we cannot recommend drug A at the moment. I recommend drug B. I would say you recommend drug B. Your recommendation drug B. In your methodology, you explain why you recommend it. You mention that we need to do this and do that, do that. You don't make it as if it's something bad, because if it was something bad, why would you recommend it? So that's the sort of argument you need to face.
Regarding protocols are extracted from and are consistent with clinical guidelines. So after developing the national guideline, you will have, sometimes even some hospitals will develop their own protocols, but it will be consistent with the national clinical guidelines. Regarding the evidence, if I find some recommendation in international guidelines and I cannot follow this recommendation in the national guideline, I can say a recommendation from expert opinions, and the grade of the recommendation will be not as high as if it is from evidence-based material. And I don't, it's not a must that I have to say that I found this in the international guideline and I can't follow this recommendation, so I put another recommendation. No, I'll put a recommendation and say that this recommendation, grade D, for example, because it's depending upon expert opinion only.
I just wanted to add a comment about what was being said about downgrading the medical practice in Egypt by adopting a lower-end guidelines. One of the very important factors while developing national guidelines is to maintain cost effectiveness, so that we have a sustainable, standardized guideline that fits everybody. Having an astronomical solution that can only be delivered to a select few before the whole system goes bankrupt is something that is not sustainable. We want something that is sustainable, standardized, that can serve everybody. Giving an example of the United States with the world's most failed medical system is not something that we aspire to have in Egypt. We want something that's more of a socially convenient healthcare system that provides a standard of service that is sufficient and reproducible and sustainable.
All of these are part of your discussion. When you have the panel, you look at the evidence, these are become part of the things you look at, and you look at them explicitly. That's why you need to have a good representative of people who can bring different backgrounds, different ideas, they can share it, so that when the guideline comes out, you see the signature of the Ministry of Health or whoever who signs the guideline, but then you can look at the panel and say, oh, okay, I see people. And that would add to the reputation there. So how are we doing with time? So very badly? Quite badly, so that's agreed. So, okay, so maybe I sit now and then leave the microphone to the next person. Yes, better. But you may also handle some hands. So it's up to you how to handle.
Okay. I think we'll just keep moving because so I want to talk about this issue around scoping a guideline and PCAS. Thank you very much. So I thought I'd just start by just mentioning what happened in the government in India about 10 years ago. There was, I've been working in India for about 30 years now, and the government in TB decided they would work with a premier institution there in developing extrapulmonary TB guidelines. And there were a few guidelines around, the global guidelines and American guidelines. But so we had about 250 people involved in this process with 13 different guideline groups. But I just want to cut to part of the story, which was the initial response of the clinicians in the premier institution and the program was to write a huge, big manual that covered everything and every step of the process. And most of it was not terribly important in terms of having an impact on health. So we went back and scoped it out with them and had the dialogue about priorities and what they could see was important, but also bearing in mind where there was evidence around that might help. And we came out with 3 questions, and I just want to describe 2 because they are relevant to this discussion about country context. One was Gene Expert, and Gene Expert was just being rolled out at the time. It was coming in new. WHO had recommended it for all pulmonary TB, but for extrapulmonary TB, it wasn't so clear. And so we updated the systematic review on diagnostics and so forth. And when we got to TB pleura, the India Guideline Committee, I thought would follow everybody else, and what WHO said was that TB pleura, you should do Gene Expert because it rules in the condition if it's positive. But the sensitivity of in this particular condition is very low. They said, no, we don't want a black box to artificially reassure physicians that it doesn't exist. So because the sensitivity is so low, we're not going to recommend it. So that is a small example of people actually making a guideline that the clinicians signed up to. The second was a really interesting example around corticosteroids for TB pericarditis. And at the time, globally, that TB, from Bongani's trial, Bongani Mayosi, who's unfortunately died now, did a trial in South Africa, a pivotal trial, that did not indicate an effect and actually suggested that corticosteroids in TB pericarditis was a bad idea. And the committee looked at the trial and the systematic review that we were putting together for them and said, but 40 or 50% of these people in the trial had HIV and they weren't on antiretrovirals at the time. In India, we don't have that amount of HIV. We want to see what it is stratified by HIV status. So we went back to the authors of the original trial, and a new analysis was done stratifying by HIV status. In that process, we found some errors in the trial from the New England Journal. And actually, at the end of the day, corticosteroids benefit HIV, probably benefit people with, that are HIV negative. So it led to a re-evaluation of the original research because the question in the country had been so focused in what they wanted to know. So I thought that that's quite a good example of the value of internalizing the information and looking at it at a national level. Is that, so I was asked to talk about PICOs, and PICOs, in this process in India, that's what we did, was we spent almost a day sort of focusing in on what the key questions were for the country around, it was Gene Expert, corticosteroids, and some around length of treatment for TB, whether it's 6 months or 9 months or 18 months. So a PICO, this is very simple, is, anybody know what PICO stands for? I'm sure somebody from, what does PICO, pardon? Population? Yep. Control? Comparison and outcome. Yeah, okay, thank you very much. Okay, so I'm just going to just very quickly say it's a way of characterizing a trial, it's a way of designing a systematic review, it's a way of identifying a search for a systematic review on a database, and it's a way of structuring a question for recommendation. I think those are all, that would be fair enough. So in a trial, just talking about steroids in TB meningitis, you design a randomized controlled trial. The design is an RCT because observational data may well be misleading. People with meningitis, you look at steroids and then you look at death and disability as an outcome. And that's the randomized controlled trial. And one of the biggest trials was in Vietnam, was done, which kind of, if you look at the data, it tells you without statistics, but the relative risk is 0.69, so you've got a 31% reduction in mortality if you give corticosteroids to TB meningitis, a big effect. So steroids for TBM, if you are considering that question in a guideline group, you wouldn't want to just know about the Vietnamese trial, you want to know about the totality of the evidence. Did all the trials show this? What was the size of the effect? So you would design a systematic review in the same way. The design is systematic review. You'd include randomized controlled trials. The participants would be people with steroids, with TB meningitis, the intervention, steroids, the comparison, TB treatment alone, and sensible outcomes of death and disability. So, and that's the systematic review of all those randomized controlled trials with, sorry it's so small, with the Thwaites study towards the bottom of that with 50% of the weight. So that's the systematic review, which would then be transferred to a summary of findings table. But so finally, PICO, to drive a recommendation, you start off then with, and these are the guidelines I was talking about, what is the question that you're trying to address in the guideline, not the research study. And it's very important that you do PICO questions that are relevant to you, not based on the availability of research. I've seen recommendations that are often based on just because there are some trials there. WHO recommended text messaging for improving adherence to antiretroviral treatment at one stage simply because there were 5 trials and people had done the trials because they were easy to do. It wasn't a terribly good, very encompassing recommendation to improve people taking antiretrovirals, really, because it was such a simplistic solution. So it should be based in what's important. And that is sorry, it's difficult with this slide, but this systematic review I showed you earlier on was the outcome of death. A summary of findings table is used widely in guidelines to summarize a systematic review of effects where everything is in a single page with the outcomes down the side, death, disabling neurological deficit, and then the relative risks in the middle and illustrative rates there. So that's death, a relative risk of 0.76. So in the population in the trials, the placebo group, about 40% of them died, 41 out of 100, and then with that relative risk, 31 out of 100 you would anticipate dying with corticosteroids, showing clinically obviously a very important effect. And the grade, which we'll do tomorrow, was high certainty evidence. So you would say that death, corticosteroids reduce death by 36%. So, and then that PICO is what gets adapted into the recommendations that it should be recommended in this set of circumstances. Okay, that's all I wanted to say about PICOs. This guideline, I don't suppose I should be using this because it's not finished yet, but the guideline development group with Echinococcus started off with the planning, considering what the priorities are, the systematic review process, and now we're in the process of making the recommendations. And the summaries of the evidence came out of a mapping of the clinical care pathway, and then, which is based on cyst size. Again, it's so small, I'm sorry. And then the PICOs that came out of that was albendazole versus pear and albendazole. These were all the comparisons, which then a team summarized the evidence for, which is then considered by the panel. So that was a very, I was asked to introduce PICOs. They're widely used in these different contexts. Pardon? Yeah, so what we'd like you to do is perhaps talk with your colleagues on the table. The three areas that were identified that were supplied to us was stroke care, chest pain and emergency trauma. Perhaps just talk with your colleagues, choose one of those, stroke, chest pain, emergency trauma, just choose one of them and talk with your colleagues about what you consider important PICOs in terms of what we're talking about at the moment, the size of the effect, where the uncertainty is, where you would. So the three topics was stroke care. You only take one: stroke care, chest pain, and emergency trauma. Just take one of those topics and talk about what PICOs you think are important to your country in that area.
Oh, and to say, we'll give this, we have half an hour, so we'll maybe give it 15 minutes for the group work and then 15 minutes to report back. So we'll come back to you in 15 minutes. Thanks. Some of you would like to have more time, but we're already very late. So, and this is not, there isn't a perfect answer. So perhaps we stop the working groups now and we come back together into plenary and we hear what your experience has been in designing these PICO questions. Is there anyone who volunteers to tell us what their PICO question is? Yes, we have a volunteer. Excellent.
Good evening, everyone. we have raised here in. By the way, my name is. Is it clear? Is it clear? Is it clear now? Okay. My name is Ahmed Ataya, consultant in neurology and neurointervention, Mataraya Teaching Hospital. We raised a simple PICO question here in our table regarding a stroke patient. We choose a population of patients with cerebral ischemic stroke, and the intervention we choose that administration of RTPA, tissue plasminogen activator as a thrombolysis, and we choose our patient outcome. The primary outcome is the functional outcome after 19 days regarding the MRS score, and the secondary outcome is hemorrhagic transformation after ischemic stroke and the administration of RTPA.
I have just one comment. It was the P. The population is. Remind me the population.
The population is patients with ischemic cerebral stroke.
So that's very broad. That can be older adults to young infants, mostly adults. So perhaps specifying the P to be clear which population is being referred to. Paul, would you have any comment on that, PICO?
I agree, you would need to specify the particular group and whether there was an absence of risk factors, but yeah, that's good.
Thank you very much. Very clear, PICO. Anyway, says the professor. Would anyone else like to share? Yes?
I am Dr. Zaglul Gouda, a nephrologist. My PICO question as a research question is urine dipstick analysis versus albumin creatinine ratio in early detection of CKD among diabetic patients. The population is diabetic patient. Intervention is urine dipstick analysis. The comparison is with comparison of urine dipstick analysis versus albumin creatinine ratio, and the outcome is early detection of CKD. Okay.
Same comment on the P. Is it all patients? Is it everybody? Or would you need to specify an age group or?
Diabetic patient in general, as screening for chronic kidney disease is mandatory for all types of diabetic patient.
Okay. Thank you.
Okay, hi. It's a group question. So the question is a patient with a typical chest pain, do we have with risk factor of cardiovascular disease, and the P is from 60 to 80. Is it essential to do a chest X-ray? Yes or no? This is the intervention, and we would like to know how many patients with typical chest pain have respiratory disease, and the outcome. How is our management differ in these patients?
So the intervention and comparator is people who get chest X-ray and people who don't. Yes. Okay. We're running after time, so perhaps we stop with the examples. But does anyone have any feedback they would like to give about this PICO exercise? Are there any particular challenges or anything that you find is useful using the PICO format that you might want to share with the rest of the group? What I would say is, from my experience, both developing guidelines and also reviewing and appraising guidelines, is that sometimes what you hear in a guideline development process is that the PICO is not specific enough. So the first criticism that can be heard from a guideline panel is that the PICO question is wrong, that there wasn't sufficient attention on each of those four elements. So either the population isn't clear, or the comparator was the wrong comparator, or some important outcomes were missing. Because we can all agree, for example, that mortality is an important outcome. But then there are a number of other outcomes that might not be the most critical outcomes for consideration, like hypothetical patient satisfaction. It can be more important or less important depending on the guideline that you're developing. So it's really, really important to spend time to get the PICO right, because if you don't have agreement on the PICO, then people will criticize the process from that very beginning. And it also determines what evidence you're looking for as well, because in order to answer the PICO, you're doing a particular evidence appraisal process, and if you don't get the PICO right, you might not get the evidence right. So thank you for engaging in this group exercise. There's going to be another group exercise coming up shortly, but first of all, we're going to hand back to Paul for this next session, which is on systematic review appraisal processes.
Just to make this a little bit more interactive, and there's a lot of firepower in the room in terms of brains. If everybody who's got a piece of white paper could stand up, and I want you, really, we're going to learn quite quickly the steps in doing a systematic review, but I want you to put them in order. And so each of you's got one. Some people rapidly passed it on to somebody else on the table, which wasn't quite the point. But the people that have a piece of paper, could you please come up to the front and start organizing yourself from left to right, the order in which you would do a systematic review. And that doesn't mean everybody sitting down. doesn't do anything, you need to help reorder them. So everybody with a piece of paper, please go up to the front and sort yourselves out. Up. Yeah, okay, yeah. Nice and easy. There you go.
He's the last one.
Yeah, go. Yeah. So the last one is on the right and the first one on the left.
Exercise as well.
You should get...
It's actually a lot of fun. Yeah, I think. Yes.
Sorry. So you come on, you got to get up there. One of you's got to go. Oh, it's right. They delegated it to you. The dynamics on the tables is nothing to do with me. Got to go. So some of you seem to be holding back with the steps. Please, everybody, please come up. Please come up. And the people that are sitting down doesn't mean that you just let them get on with it. Push them around a bit. Come on, there's usually a few bossy boots. Come on, let's have some focus now, please. Do we need some WHO consultants to help? It seems the people at the end seem to know what they're doing. Yeah, peer review, but this is the protocol. Well, this is we'll find out. You make the decisions. You're the people. You need to be that way a bit. You need to be that way a bit. Yeah, you're doing. I must say, the front, the people have started all right, but the people in the middle are in a bit of a muddle. Still, yeah. No. Just you're getting there. Complete the abstract. No, you're too high. You're too high. Too high. No. Start, end. So, do you think that, can you see any reordering go on there?
I think we can just pass the mic from left to right. I can go through them and then we can discuss together.
They've got to get it right. Yeah, I'll do that. Don't worry. But they're right. After bit further down. Hang on a minute.
After the inclusion.
You're good. This way a bit, sir. Yeah, fine. Yeah, I think you might be there. Oh, no, you swap.
Here?
You swap. Yeah, hang on. But you're looking at me, you should be working it out yourself. Yeah. Yeah, just go in there for the time being. Oh, okay. Well, that's good. So, you need to be up a bit. Just here, and you need to come after the systematic search. Right. Well, swap.
Yes, switch.
Up a bit. Here. It's a sort of yeah, that's about. Okay, right. They're pretty good. So, so thank you very much for ordering yourselves so well. So I know we had some difficulty with the peer review, but thank you for taking feedback. So I'm just going to run through these in a way. So a systematic review is a... Oh, okay. A systematic review is different to a narrative review in that it has a research question. So you need to work out the research question. You put a research team together related to the research question. Sometimes you start with the team and then the question, so those two sort of slightly interchangeably. Who do you think should, a narrative review would often be one topic specialist. What sort of people should be in a review team? What sort of skills are you looking for in a review team that you need? Sorry, sir? Motivated. Motivated. First, it's got to be motivated. Pardon? Yes, well, what disciplines do you need? We're on putting the research team together. So it doesn't matter, so what sort of skills do you need? You need a clinician, statistician. Yeah, it's all flowing out now. We got it. Economist, not necessarily. A statistician. Statistician.
Which is an epidemiologist.
Yeah, statistician, methodologist. So we're somebody with so often a methodologist in systematic review. A statistician is different to a methodologist. A statistician has a particular set of skills. Somebody said computer technologist, and I think somebody that knows how to search the literature is very, very important because it's a specialist skill. I have no idea how to do it. So you need a multidisciplinary team. You need people that have content knowledge, but the content knowledge should not be highly dominant, and you want to avoid them being people that have actually done a lot of the trials because they will drive the agenda. So a systematic review will start with a protocol, which is the materials and methods of the review. The protocol will have the objectives, the inclusion criteria, in other words, the type of studies that are being included. You might include, generally for an effects review, randomized controlled trials. And it has methods, we're right. So then, you have peer review, that's right. So you would check that you're on track. You would this would all be written up like any other piece of scientific research, and then you would check with specialists and statisticians that the methods were correct. And you would either register that on Prospero or publish it as the Cochrane, or publish it in journals now. So that's all important part of it. The peer review helps quality assure, check the outcomes. There are things that you might do about standardizing the outcomes in the methods and so forth. So then you would systematically search the literature. You'd get can you just swap? Yeah.
Swap?
Yeah. No, just there. Just that one. That's it, that's fine. So we could have just got swapped the paper. Search the literature using a particular search strategy. Screen the abstracts, go through quickly. Some of them will be commentaries. You can quickly screen out studies that don't seem to be right. And then you say, well, these pile of abstracts look as though they may meet the inclusion criteria. So this is critical. And the point of peer review and the inclusion criteria is little changes in the inclusion criteria or slipping a study in that doesn't quite meet the inclusion criteria is not uncommon and can completely flip results. I can give you a paper that shows how that happens. So then you pull out the full text of those studies that might meet the inclusion criteria, and you apply the inclusion criteria carefully. So you'd often have two people doing this to make sure they both agreed that the study went in with a third referee if it was unclear. Because as I say, including or excluding a study for whatever reason can change results. This bit people often get wrong or don't realize. The first thing you do when you've got the pile of studies is a systematic review is actually a descriptive study of all the studies that meet the, that may well help answer the question. So part of a systematic review is simply describing the design, where studies were done, who the participants are, the locations, the doses of the drugs, if it's a complex intervention like stroke care, what the components of the intervention are. And then, and only then, you get to look at the risk of bias or whether one study is more reliable than the other, and that it follows criteria that are indicators around whether risk of bias is high or low. You then, and it's only here that you actually start looking at the outcomes of the study. So if it's a randomized controlled trial, how many people died or how many people survived? That's, 2/3 of the way into the process, if you see what I mean. So you don't hone in on the results. And the point of a systematic review is you include studies irrespective of the outcome. You don't include studies based on the results of those studies because that causes bias. If it's a quantitative study, you will conduct these plots and analysis, combine data where that's necessary. If it's a guide, nowadays grade is such a clever, grade is such a strong tool in interpreting evidence that this is often done, and we'll have a look at that tomorrow. And that allows you then to interpret and write up the results. The grade was like the summary of findings table I showed you earlier on, but it actually allows you to use words to express your certainty. So if it's high certainty evidence, you would say corticosteroids reduce mortality. And if it's moderate certainty, you would say corticosteroids probably reduce mortality. It actually allows you to write it very clearly. You complete the abstract based on all of this. Yeah, we should referee it first before we copy edit it. So you get it refereed, get it checked, get people to check that all the studies are in, the interpretation is right. Copy edit the review. People forget this. Just means make it accurate, make sure everything adds up. A review that has data that doesn't correspond is immediately discounted, particularly if it goes against what current thinking is. And this is the Egyptian team we've got here are obviously rather a tough team because they don't allow you to have a beer or mango juice or a lassi until much, much later. They say, yeah, they've got to update it first. but I mean, we put this in because you might... Yes, it is. You might publish a review first, publish it, and then you might get comments in. You might have made a mistake. There might be a new trial. You'd update it. I think you should have a beer, lassi, or mango at several stages during the process. But you all did very well. Thank you all very much. If you. We can send you. Oh yes, you can have it.
Thank you very much.
Thank you. Thank you for passing. Very happy to take them back. I know that one or two of you want to keep them as souvenirs, and that's okay. So, are there any questions whilst the next exercise is handed out? Was that okay? Okay. Okay. Can do, yeah. We can pass it out, yeah. Okay, yeah, they'll be sent, yes, okay, we can do that, yeah, no problem. Do you want it as a? I'll talk to them. Okay, so, So, if you're comfortable with this, we can move on to the next bit. Yeah? So I'll move on. So now you understand the steps, and we talked about the importance of a protocol being written in advance. We talked a little bit about the importance of the search strategy, and so forth. And this is the process of doing a systematic review related to effects. We emphasize that a systematic review is like a cross-sectional study at a point in time of the available research. When we did the Artemether lumefantrine review, we published it with 200 people in it, and the next day a trial of 800 people was published, and the review was immediately out of date. So it is only a cross-sectional study, so it does you need to take that into account and to make sure that all studies are included. So often people as senior as yourselves will not necessarily be doing systematic reviews, but will be reading them in journals. And what we just wanted you to do is to use an appraisal tool. Critical appraisal is about checklists to help you think. And the AMSTAR tool for appraising systematic reviews is a common tool. I have cut it down a bit to make it a bit shorter for teaching. There's 10 of the main criteria here. I'd just like you to perhaps go through with your neighbour the ABSTAR tool. You've got 2 abstracts. There's no point in doing both. I just choose one. One is about episiotomies, and one is about directly observed therapy for TB. And this is only the abstract. The actual full reviews are much larger than this, but I think you'll be able to get at least 3/4 of the AMSTAR from the abstract. Okay? So just go through with your neighbour and just discuss it and go through, choose one example and go through the AMSTAR and complete the AMSTAR, and then we'll have another discussion. Is it clear to you?
Thank you.
Okay, thank you. I think it'd be.
We don't have copies on my table.
I'll take those. Hang on. Anybody missing the sheets? Anybody missing sheets? Are you? Okay. Have you got the? Yeah. Yeah, you need one between two, really. The intention was for you to choose one. If you finish that and want to do the second, that's fine, but the intention is to do one well. Because you've got an abstract to two systematic reviews, one around TB and one around episiotomy. Just do one. Just choose one and go through the. So we've given you a choice, or for the people that want to work hard, extra work, but there's two systematic review abstracts are contained. One is about directly observed therapy, and one is about routine episiotomy. Choose one of them and appraise it. Right, colleagues, we threw this at you without much background, but that was the whole point, because you're very clearly know quite a lot from what we've seen to date. And just to say, I would anticipate us finishing in about 15 minutes, and I think lunch will be a bit earlier at 3 o'clock, so that'll make everybody happy. So you were given an abstract of 2 reviews, one about directly observed therapy for TB, and one about doing selective versus routine episiotomy. And rather than, ma'am, okay. Rather than go through the AMSTAR twice for each, we'll do each criteria for each review, and we'll start with TB and then we'll go to the episiotomy, because it's simply to help you pick out things you should be looking for. So some of the questions are not easily completely identified from the abstract only, and I apologize for that, but I didn't want to give you like a 60-page review for you to appraise at this stage. So it's a rapid appraisal to get you to understand. And it says here, number 1, was an a priori design provided? The research question and inclusion criteria should be established before the review is conducted, or was the protocol reviewed? Could any of you detect this? What were your responses to this? Yes, sir. No. You are correct. This, there is no information on the abstract that this is an abstract. We're talking about both of them, but both TB and episiotomy. For both of these, the format is such that it doesn't say we wrote a protocol in advance. It's because that's how Cochrane operate. Everybody, Cochrane has a rule that only reviews with protocols are published, and it is buried in the meat of the review. But you are right in saying this abstract does not tell me that this was written in advance. Now, the reason for writing a protocol in advance is partly to follow a scientific process, but also, to be honest with you, to help you write a clear review. So quite often I have people come to my office who've written a review without a protocol, and they've started with a pile of studies, and then they've fitted the review to the pile of studies. And that's how the old-fashioned way of doing it, and you get into such a mess doing that. It muddles the review. You don't have a clear question. So writing a protocol is a really methodologically to your advantage. Was there duplicate study selection and data extraction? Does anybody like to answer that for the TB review? Yes. And where does it say that, sir?
They said that 2 review authors independently assess risk of bias of each included trial and extracted data.
Thank you. Thank you. And how about the episiotomy review? Were the 2 authors involved? Yes. Yes. Okay. Thank you. So that is fulfilled. That's a tick on this. And as I say, the reason for this is that everybody has biases, people make mistakes, and it's important that it's done independently, often with a form, so it's transparent. Was a comprehensive search of the literature performed for TB? The search is very similar in both of them. Let's start with TB. Is the TB one, is it clear? Is it a comprehensive search? Yes, sir. No key, that's a fair point. That's a fair point. That's a fair point. There are no keywords specified, and I understand that. If you had the full review, there might be in one of the annexes, but you've picked that up correctly. How about the pregnancy and childbirth group? Yeah, it just says one register, doesn't it? And I think you're all right in criticising both of these, because it's often in Cochrane they set, and I've been part of it, they follow processes that they assume everybody else understands, which includes a comprehensive search put in an annex. But I accept both of those. So, yeah. Well, you could say you can say no from the information that you are given. It's not clear. It's not clear. So we're agreed in the limited information I've given you that it's not clear. So you don't know. So it raises. So the thing with these appraisal checklists, it raises a question that you then may wish to interrogate further. There's a lack of clarity around the search strategy, or there's a lack of clarity around whether two people did it. It raises an alarm. Doesn't necessarily mean that you reject the review, but you just store it in your mind, in your interpretation. So all of this is about looking at the findings in the light of the certainty of the evidence and the quality of the review. So that just, in critical appraisal terms, in the science of critical appraisal, you don't have full information. It doesn't mean that you boot it out. They might have done it, they might not. You pause it and say, let's see where we get to later on. Was the status of grey literature used as an inclusion criteria? Anyone? Grey literature is unpublished studies. Do they state anywhere in either search we searched? No, correct, they didn't. They don't. It's not mentioned anywhere. This is a really interesting debate. When I first started out in systematic reviews in 1991 or something, there was a lot of studies on Medline that were randomized controlled trials that were not properly indexed. And so the first thing that happened was indexing was taken much more seriously. That helped improve pickup. But what is the other issue with inclusion criteria going beyond studies that are unpublished literature? Why is everybody so obsessed about what about the unpublished studies? Where does that anxiety come from? What is it you're concerned about in terms of bias with this? I thought it was the camera. I thought you were answering. You're actually moving the camera. Yes, please say that you're concerned about trials that don't show an effect or negative. Correct. So it became very apparent during the process of doing systematic reviews that studies that did not demonstrate a difference were less likely to get published. The authors of the trials were less likely to write them up, journals were less likely to publish them, and people were generally less interested in them. And so if you're doing a systematic review, for example, of TB steroids in meningitis, and all is in the published literature are studies that show that corticosteroids are effective, and all the other studies are not published, then you have a bias which tends to exaggerate any effect.
Yes, sir.
Another factor in the unpublished trials, normally, if you have a rare disease whose a sample size is small, sometimes it is very difficult to publish it, and this is a bias because we are examining a point on a rare disease. So even unpublished studies here are very important.
Absolutely correct. Okay, so thanks for that. So there's been big initiatives in terms of ensuring now if you do a randomized controlled trial, you have to publish the protocol in advance on a protocol register. Most journals will not take a paper from a randomized controlled trial unless it's been prospectively registered on one of these registers. That, however, doesn't necessarily mean that the studies get published. One of our reviews we knew about a study of 1.5 million children in India that's the biggest drug randomized controlled trial ever done. I even had the manuscript on my desk for many years, and the reason it was eventually published in the Lancet, but it was 8 years after the trial had been carried out by some very good people in India and some very good people in Oxford. But it was clear that it did not get published because the results did not show an effect, and people in global policy didn't want to hear that vitamin A had no effect and deworming had no effect. So the fact that a trial is registered isn't always a guarantee of that the bias evaporates, because people still are slow to publish the studies sometimes. Is that okay? Good. One of the other reasons for ensuring people publish their protocols for their randomized controlled trials is so that they define the primary outcome in advance. So what can happen is if you register a trial, if you do a trial and then you get the results and you haven't decided on your primary outcome, you draw lots of analyses and then you pick an outcome that shows a statistically significant difference between the two groups and present that as the main results of the trial. And that brings in another source of bias. So it's very important to see whether the review checks that these trials report correctly the primary outcome. That's called selective reporting. So was a list of studies included and excluded provided? You can't tell that, can you, from what you're given? If you were looking at a review, you would look for the studies that are included and the studies that are excluded. But you can't tell it from the abstract. I tried to do a simple example to help us move forward. One of the reasons for including the excluded studies is so people don't say you've missed a study when actually you've excluded it. It's a very useful approach. So it's very transparent what's included and what's excluded. Now we're getting on to the presentation of the results. For TB, is there a description of the characteristics of the included studies? Anybody? Yes, sir. Yes. And for episiotomy? Yes. Okay. So it says early on, the 6 trials done in what countries with self-administration, family member, community health worker. So the first part is this description of the studies, and with complex interventions, you need to know what the components are, so that's important. And again, in the study of episiotomy, it's clear whether they were done in prima gravidae, multigravidae, and so forth. Okay, so the description is very much part of understanding studies that have been done. If you look at studies of antibiotic treatment of infectious diseases, you need to know what years the studies were done, because antibiotic resistance changes, and studies done a few years ago will be probably entirely irrelevant now. So you need that to help you interpret. Was the risk of bias included in the studies? Yes or no? Was there a description of the risk of bias? Yes? in both of them? Was it? Yes, risk of. So they describe the level of, in terms of, and one of the most important things in a systematic review, which I didn't emphasize, is old-fashioned reviews used to take the results of studies and take the only and state it as if it's a fact. The point of a systematic review is to look at the risk of bias, take the results in the light of the risk of bias, and say how confident you are in the results, right? So that means that less reliable studies are more uncertain and less likely to give you a result. So what used to happen in the past is people just say, vitamin A works, you know, we got a study of 300 people. But what you do now is say vitamin A in 5,000 people was very effective, and this is high certainty because the risk of bias is low. So this mistake continued in Nature microbiology reviews last month. They misquoted one study of 400 people, an observational study, and said this was evidence that a physical exercise was harmful in the post-COVID syndrome, which is just nonsense. It's selective reporting. So it's very important the quality of the research is taken into account. Now, were the methods that combine the studies appropriate? This is a hard question for you here. You kind of need the graphs to look at it, but there's certainly some statistical combination going on in the studies. Unless you've got the graphs in front of you, it's hard to understand it. But one of the things you might look at is how the reviews are structured. In other words, with directly observed therapy, as you see, it has a number of headings: DOT versus self-administered, DOT at home versus DOT at health facility, and so forth. And those are comparisons. So this is trials that compared that with that and the results from that. And in the episiotomy review, that doesn't happen. I think there's midline episiotomy. There was one trial in midline episiotomy right at the end, but that doesn't happen. But that's a stratified analysis by the comparison, right? So if you were in a guideline panel, you would be, and you were interested in DOT at home versus DOT at a health facility, you'd take the middle comparison as the evidence for that. So that's why the PICO that you define in the guideline is important to map it on to the systematic reviews and the trial evidence and make sure there's not some conflating going on in the process. So has GRADE been used to summarize the overall certainty? That's a little bit early for you. Does anybody want to make a statement about whether GRADE has been used? Well, although it should be in the methods. Yes, it's mentioned in the methods. And then if you see each of the confidence intervals, for example, if you look at the directly observed therapy, DOT versus self-administered, go right down to the bottom. Treatment completion showed a similar pattern ranging from 59% to 78% in the self-treatment groups, and direct observation did not improve this. Relative risk 1.07, confidence intervals tight around that, moderate certainty evidence. So that's saying there's probably little or no difference. Okay, so where you see moderate certainty, that means, or low certainty or high certainty, that means the GRADE method has been applied. Were conflicts of interest stated? there's a hypertext link that I left in. So there is a section in the review that states authors' conflicts of interest in this. So, and one of the things in reviews that's very important to check on is whether the authors of the review are authors of the primary research studies. Why might you be concerned if the author of a primary research study was also an author of the review? Why might you be concerned? Bias, yes. What sort of bias? What's going on? Yes, so you would expect somebody, and we all know these trialists are terribly thrilled about their research, aren't they? And that their research is going to change the world, and they want it used in guidelines, and they will, quite naturally, I'm not saying there's anything wrong with it, but they will be biased towards the results of their trial, that their trial is wonderful. They'll probably, their risk of bias assessment may not be independent. And so you'd be concerned about that. Increasingly, people are concerned not only about financial conflicts of interest, but also positionality of people, of what angle they're coming from, what is their, what do they think about the intervention, what's their background. And I think we'll see increasingly reflexivity statements coming in so that you understand what the authors are where the authors are coming from. And indeed, part of the reason for having a team and for having peer review is to have those checks and balances within the team. So when we started on systematic reviews, often specialists didn't like it because they felt they should be in charge. But actually, they're very important, but the methodologists are the important people to make sure things are independent. Okay, so thank you very much. Thank you. So that's a quick whiz through. Thank you for your attention. If are there any questions? I think lunch is going to be at 3. And tomorrow we'll be looking at grade and evidence to decision-making framework. So we've got quite a long way across the top bit of assessing summarizing the systematic reviews, and then we're going to swivel down and look at the evidence to decision-making framework. But before we do that, we'll show you what grade is, because I think you'll love it. It's really, really a powerful tool. Thanks.